So congratulations on doing very well on your last test, guys. Very proud. I think that's the first time I've had a class pass a test all in the first go. So well done. I will send you the review for the next test today after we finish lecture. And now I can't find my Google guys. Hold on.
Nicole, I have a question.
Yes.
The next exam is gonna be on what, chapters 1 through 12?
Well, yes, I believe so. The next time you're in
Okay.
person is the 17th, correct? So the only lectures we're doing are 1 through 5, 6 through 9, comma 12, and 10 and 11.
Okay.
Okay.
Thank you.
You're welcome.
And Nicole, do you already have those review sheets done, or do you do them?
So I didn't do them. So I did not put together the review sheets, nor did I put together the tests. I reviewed the tests afterwards. One of the other instructors put all of that together. Questions, comments?
So I was just gonna see if we could get those review sheets before the chapter that we're doing. Like if we could have had this review sheet instead of after this class before it.
Hold on. Stand by. Questions, please let me know. Pop it up. Onto bless you. I forgot what I was saying. All right. Throw any questions you have up in the chat. Go away, little. Thank you. All right, EMS system. This is going to be the first one we're talking about today. So, EMS, we talk about the history of EMS like all the time, and then we don't test anybody on it. We're relatively a young profession. EMS really hasn't established itself as a real thing until like the 1970s. Prior to that, they kind of just did what they wanted. They had horse-drawn carriages. Bellevue was like the original EMS department where they started moving things. At one point, they were doing a lot of pretty much just picking people up and bringing them to the hospital, regardless of actually providing care. They had originally put doctors on these ambulances and these carriages, and then that got too expensive because they needed the doctors inside. So then they just put orderlies. EMS pretty much got its start during wartime, and it's still a lot of the stuff that we do in EMS is based off research that they do in during wartime. So like quick clot and stuff like that has all been tested in military skirmishes. We are brought to you by the National Highway Safety Act. They are in the Department of Transportation, are the kind of reigning bodies of EMS, which makes some sense and then makes no sense all at the same time. We really, if you kind of think about it, should kind of fall more in line with the Department of Health. But that, that's never going to change. But us and the truckers. So in the 1970s, EMS really started to kind of not only solidify itself as an occupation, but they created the show Emergency. Pretty much was a public service announcement show. So they were trying to get people interested in joining the EMS and fire services at that time because there was a need for it. At that time, the NHTSA also developed what the 10 elements of the EMS system was. But at the same time, they also then reduced federal funding and gave it to the states. So each state has the ability to, decide how much money. And if you're like kind of in the New York State area, you see how that kind of comes down, right? So you have each department gets their money, their budget, especially the volunteer side. New York City is a completely different monster as compared to Nassau and Suffolk. So there it is. So just a lot of different things going on. But that's where our funding comes from. Again, now because they federally kicked the ball down the road to the states, our authority to function as a paramedic is divided into certifications or licensures depending on which state you're in. So here in New York State, it is a certification. It's basically saying everybody here can work at this level of care. Whereas a licensure is a little bit more well defined. It's like a statute, what the scope of practice is. It's legally, and how do I put this? Legislatively, it's a little bit more. Right, so nurses have licenses, doctors have licenses, they have functions and scopes of practice that they're able to do as, a nurse or a doctor. Whereas where we are in terms of certification, they're like, well, you have to have these basic skills, right? You need a CPR card. But that's kind of about it. It just gives you the basics. It doesn't really give you, and then it kind of gives you the upper level, right? So they're like, all right, so you have to have a CPR card, but you can't do a perimortem C-section, right? So it kind of defines it, but it's a lot looser. So like, for example, as a paramedic, if you're working for a transport company, there's nothing to say that if your transport company trains you on how to use a ventilator, that you can't use a ventilator. So that's that kind of weird, loosey-goosey kind of vibe that certifications give you, whereas licensures are a little better structured. We do not have that in New York. We do have reciprocity, however. Each state has different certifications. So what they've done in New York State is that you are no longer taking a state exam, you're taking the National Registry, but in order to be considered a New York, to get the easy quote-unquote reciprocity, you apply and have said that, oh yes, I've done a New York State paramedic certification exam, or class, not exam. So there are plenty of states where that New York State medic certification will give you a, Connecticut or Pennsylvania certification. But the way that they're changing everything, they're sort of starting to push towards this national registry for everybody. That could change. And again, a lot of people they're putting different limitations on who can do what. Like, for example, like New York State. A number of different EMS systems exist. Even in New York State, we have a variety of things that are going on. A lot of in New York State in this area is it's a municipality or fire vac based. We do have a good number of private people who participate. Out on Long Island, most of those privates are interfacility only. Whereas if you get into the city, those private third-party people do participate in the 911 system. So like Senior Care, for example, provides contracted EMS services for like Beth Israel or up in that area. And then you have hospital-based, which if you look at really high-functioning EMS systems, most of those are hospital-based because they have better resources for EMS to act as a healthcare provider. The problem when you kind of get into the fire-based in the municipality is you don't have the structure that you do as a hospital, right? You don't have, CMEs brought to you by doctors. All the doctors who are participating are kind of free agents. They have no loyalty to the hospital or to making sure that patient care is high quality. My personal issue when it comes to fire-based EMS systems, especially out in Long Island, is that a lot of the focus goes to fire training. That's great. That's wonderful. Put the fires out, but you need to do an equal amount of training for your EMS. And sometimes, depending on the department, that gets very lost. Another problem is like the way that fire-based is a lot of them still use the pager system. VACs do a fantastic job of having a duty crew, whereas a fire-based system does not. It's respond to the pager. So your response times are greater, and you don't necessarily have the ability to roll an ambulance if you don't have, at least one EMT. A number of different factors will determine how well your patient outcome will ultimately be, right? So starting from the top, bystander care. In the New York City region, very, very lucky if you have anyone providing bystander care. Most of the time, that bystander care is like a family member who may or may not have some level of training, of healthcare provider training.
First, the caller who walked away prior to arrival.
Oh yeah, all the time. People like, I didn't want to touch him, and you're like, because he's a professional outdoorsman. Got you. That's why you didn't want to touch him. And you know what? I don't really blame a lot of city folk for not necessarily wanting to get involved, but still wanting to do the right thing. There's a lot of people out in the city who have mental health issues or could be completely unpredictable. I don't blame you. Like, you don't necessarily want to put yourself at risk. There's a lot of EMS professionals who are also kind of like, I don't really want to put myself at risk. Like, but it's my job, so I'm going to. But yeah, there's a lot of that. The third party caller who then is no longer on scene. Dispatch and pre-arrival directions. This one always gets me. I can't tell you the number of times that you read the dispatch information and it's nowhere even close. For example, the other day I had a 4-year-old difficulty breathing. And then later in the text, he's a 44-year-old. And I was like, that changes what I'm going to do dramatically. If you look at your protocols, you have a whole set of pediatric protocols that's way more weight-based, as opposed to, adult protocols, which you have kind of standard dosage for a lot of stuff, such as epinephrine. So, accurate dispatch and pre-arrival directions are sometimes hard to find. Your response, right? Mode and distance. Most areas in the United States are ground transport only, and we're going to talk about modes of transportation here on the bottom as well, right? So most of us, move around the world in a regular old standard 6-wheeled ambulance. Yes, 6-wheeled because we got the dualies in the back. And then distance, right? How far is it that you're going to respond to this call? In the city, you could be going a half mile and it still takes you, 5 minutes to get there. City distance and, Long Island distances are totally like there's a time warp that goes on, like, right? A half mile should not take you that long, but you're dealing with city traffic and lights and pedestrians and all sorts of other congestion one-way streets that could complicate what that half mile is. Just because it's a half mile as the crow flies does not mean you're going to get there in a relatively decent amount of time. Ambulance, helicopters, right? Personally, there's very little reason there's zero reason in the New York City area, except for like 1 or 2 locations, for a helicopter. It's just not really practical. It's extremely expensive. It's extremely dangerous for the provider. And really, you're not going to expedite transportation that much because it's not, the infrastructure for a helicopter is not really here in New York City. Out on Long Island, maybe. It's either police based in Nassau or police/Stony Brook based out in Suffolk. But again, there's a lot of factors. Like today, it's gray and rainy. They might not fly because the conditions aren't suitable to safety. So they may not go up. If it's too windy, they might not fly. So yours could be sitting on scene waiting for a helicopter that's never going to come, right? A lot of the times we call, or the volleys call for a helicopter for bad traumas. That patient needs a trauma center, yes, but definitely heard of, they take them to the landing zone and they're waiting. And that patient could have been at the hospital, right? We have that platinum 10 minutes when it comes to trauma. Geographically, there are a few places that would benefit from helicopter EMS, such as the Far Rockaways, and like the Hamptons, North Fork region, right? There's no hospitals nearby. The Hamptons and North Fork is one way in, one way out, similarly to the Rockaways. So you have a lot of complications when it comes to trying to be able to transport somebody. I learned the other day that apparently the closest pediatric trauma center to Rockaway Beach is Staten Island. And I went, no, we're going to Cohen's. So, it's going to be highly affected by your time of day, especially in New York, in this area, right? You have traffic. You have the Belt Parkway, you have the Van Wyck. For any of you who have not worked in the city, the Van Wyck is a 20-year construction project at least, right? So there's just traffic. There's a lot of traffic. There's a lot of people. Let me close this window, maybe. I'm gonna die. Hold on. I got chilly. So a lot of factors. Pre-hospital care, right? There's this ongoing joke that ALS kills trauma patients because we sit on scene too long and play. Not wrong. Again, you need to make sure that you are taking the patient emergently, depending on what their condition is. ED care and like specialty care, okay? Right? Almost every emergency room can kind of take care of a patient. Kind of. So, are you going to take that multi-trauma patient to St. Joe's in Plainview, or are you going to take them to a trauma center, right? Are you going to take them, how about this, Plainview or Huntington? Huntington's an actual trauma center. Plainview is like kind of a community-based tertiary care center. So you need to make sure you are familiar with the hospitals in your area and what's the most appropriate. There are some hospitals that don't have accepting labor and delivery. So you need to make sure that you know where those are. Stroke centers. New York State is kind of a unique location where most of our hospitals are stroke centers. I think like 98% of them are. There's one or two that's like a freestanding that's not. But now we're moving to what's an LVO center, right? How are we going to determine if the patient needs to go to an LVO center or needs to go to a regular old, whatchamacallit? And then afterwards, this is rehab. That's beyond us at that point. That's maybe if you're doing interfacility and you're taking a patient home or to a rehab facility, right? How is that patient going to be able to recover? What steps did we take as EMS providers to set them up to make it to rehab? Did we appropriately splint their injury? Did we get them to the hospital promptly so that, they didn't lose too much blood and they actually have a positive outcome? Did we recognize that they were having a stroke and make sure that we got to a stroke center within that 3-hour limit from onset, right? So a lot of different factors will determine how the patient does. And a lot of things also depend on how healthy the patient was prior to whatever their emergent incident was. So for example, if you have a patient who only eats fast food and only drinks soda and does nothing to do any of the good for themselves, like take their medications, they're not going to have a good outcome no matter how good your EMS care is. Okay, so there's just a lot of things to take into consideration there. Various levels, right? So we've eliminated the EMT-CC and now we just call it the AEMT to align more with the national levels. So we have an EMR and aka the CFR, these your firefighters. EMT, AEMT, medic. After medic, you can move on to critical care. A lot of people move on to nursing. We lose a lot of EMTs and medics to the nursing profession. You could do interfacility transport. There's community paramedicine and mobile integrated health, which is like an up and coming area. The problem with community paramedicine is we don't have a good structure to bill for it. So that's complicates these programs being super successful. You also have to compete with visiting nurse services who get very persnickety when we start stepping on their toes. You could also move into emergency management. I know plenty of people who, EMTs and paramedics who have worked for OEM in the city. FDNY, they actually have a post, so they'll put people there for the emergency management side of things. A lot of hospitals also have emergency management departments. So, like for example, if they're anticipating that they had this the other day at Jamaica. There was an overturn on the belt. There were 5 patients, 1 black tag, 2 red tag, 1 red tag, 2 yellow tags, and a green tag. So they contacted once they go over, emergency management gets notified that they're coming in with this this MCI, these multiple patients, so that emergency management can then coordinate beds and coordinate CT and coordinate all these other things, so that the hospital does not hit that like crisis stage. Emergency management was very busy during COVID. Then you have public health opportunities that you can do with your paramedic degree or certification. And then you can also move into the education side, and you could teach future generations. We're going to skip that because I don't remember what that is. Roles and responsibilities of EMS as a whole. Preparation, right? Check your truck. Do you have air in your tires? Respond. Do so safely. Scene management, when you get on scene, are you keeping your head on a swivel to make sure that you're not getting shot by an EDP? Are you effectively blocking traffic? What needs to be done, right? This is your BSI scene safety additional resources step, right? We teach you all of that, and your BLS portion of life, it doesn't change. The parts where we start to change as medics are your patient assessment and care. Your patient assessment should now be probably a little more thorough than it would be if you were BLS. We're just providing you with a lot more knowledge, at which point you should be able to generate new questions, better questions, to kind of get more information from a patient. You should have a more accurate differential diagnosis because now you have better information. And then your care is going to change a little bit because now we've expanded how much medication you can give, what procedures you can do, etc., etc. Management disposition. Are you recognizing if your patient is critical or not? Excuse me, right? So where are you taking that critical patient? Are you going to take them to a trauma center? Are you going to take them to a heart center? Then that kind of rolls into your patient transfer and report. I cannot tell you how essential it is that you give a good patient report to the nurse, to the note doctor, to the doctor on the other side of medical control. Any of those things. You need to make sure that you are clear, that you are orderly, and you have like efficiency in what you're saying. I always have an issue when I call medical control because I just speak quickly. So for the most part, they're like, oh my God, calm down. I'm like, oh my God, I'm not freaking out. This is just my normal cadence. So you have to make sure that you sometimes take a deep breath and slow yourself down because you don't want to come off as you're panicking, which just happens to be my personal issue. And I'm like, no, you're just moving too slowly for me. I've already treated this patient and I've moved on, but you're slowing me down. Then you have documentation. Another thing I cannot emphasize enough. Please make sure that your documentation is on point. And we're going to talk about documentation on Monday. But you have a dictionary in your pocket. If you are not sure how to spell something, check. If you're not sure that the word you are using is appropriate, check. If you're not sure you've done your protocols 100% the way they're supposed to be, check. Because there is zero reason that you should have any mistakes in your documentation. Okay? I am a huge proponent of setting up the scene. You should have a very clear description of what you walked into and then what you did. And then what happened? Did the patient improve? Did the patient not improve? Did you render a treatment and the patient says, no, I don't like this. You tried to put CPAP on the patient and the patient ripped it off saying they're too claustrophobic. Okay, cool. Tell me these things. If you write a very clear description, you will never ever have QA/QI issues. You will never have issues if that gets brought to court. and make sure all parts of your documentation are thorough, not just the narrative. The flowchart also needs to be thorough, accurate, and mesh up with your narrative, because sometimes a lawyer will hand you just your flowchart, or a lawyer will hand you just your narrative, and they need to match, because that's a lawyer's job, is to try to jam you up. And then your return to service, it should be prompt. You should be back part 800. Everything should match in terms of what you need on the ambulance. I used a leader bag, I replaced the leader bag, etc. Questions, thoughts, concerns before we move on to this other new slide. Slides.
Have you ever been called to court?
I have not.
I have. It sucked.
Right? They try to tear you apart.
It's because you get called by both the defense attorney and the prosecuting attorney, and they're going to try and pit you against each other. I actually almost got jammed because the defense attorney called me beforehand, and the fire department gave me my orders to go see them.
Mm-hmm.
So I did. Well, the prosecutor flipped out about it and shredded me on the stand, because you have to stick to the facts. What you see, what you did. There is no opinion on it, what you think.
Yeah.
You know, the case I was called to was actually several of them. One of them was a rape case. You know, I can't really attest to what happened. All I could say is what I saw.
Mm-hmm.
You
And
know,
that also means any statements that the patient makes to you. So you need to also just make sure that that's clearly documented.
and then for people who have military experience,
Mm-hmm.
I got called to a gunshot, which it was a DOA, 3 shots to the head. They actually tried to make me an expert witness because of my military background.
Mm-hmm.
Asked me about trajectory and everything else. The problem is, I was never certified in ballistics.
Yeah, that's challenging.
From when I went to court, I've noticed that if you put everything that happened into just facts in your narrative and in your whole PCR, it shouldn't really matter. You can get grilled on the stand all you want. It doesn't make a difference.
Mm-hmm.
You know what happened, you know?
And the other thing too, which is good, is with documentation, is if your report is thorough enough, legible enough, and they can paint a picture, they'll interview you over the phone and then not even call you in.
Yeah, a lot of the times they won't even need to, because the document speaks for itself. I mean, unless you really want the overtime, but I don't think anyone wants the overtime by getting shredded on the stand.
No, I collect the overtime from the phone.
All right. So yeah, see, great reasoning why you should make sure that your documentation is.
Oh, and there is no time frame. You can be called to court 5 years later.
It depends on statute of limitations.
Yes.
Some case types, there are some case types there are not. But yes. So if you did a job five years ago and they're like, hey, I need you to come testify in this, you're like, I don't know what I did. I don't remember this call. If you documented very clearly, you'll remember. Like, you might have done 3,000 calls in between, but you've painted yourself a picture. It's self-protective as well. So medical direction, right? We have 2 types of medical direction. Online medical control, that's when you call and say, hey doc, I've got this, this, and this. I'd like to do this. What you think? And they say, yeah, no, do that, or yeah, no, don't do that. You could also potentially have an on-site field physician. I've had a medical control physician show up on a grand total of 1 of my jobs. It was the day after Christmas, or Christmas Day. He had been restricting FDNY guys in Manhattan the day before. So, like, everyone's like, just be careful. He's out. He's very active, and he lives in the Queens area. And you're like, oh.
Dario Gonzalez?
Nope. I forgot his name, actually. But working up an arrest, go to call for orders. Guy's a dialysis patient, and we'll talk about this when we get into pharmacology. But I wanted to give him calcium and bicarb right away, because that's what dialysis patients need, because most of the time their cardiac arrests are secondary to an electrolyte disruption. So I get on the phone. I'm like, hey, 5-1 Victor, I need orders in an arrest. And all I hear out the corner of my ear, and I see out the side of my eye the canary, this carbon monoxide detector. Are you on the phone with medical control? And I turn, I'm like, yeah, thinking it's a firefighter going like, why do you care, dude? And he's like, Doc. And I was like, oh, no, you're on my scene. Okay. I was like, all right, well, I'm gonna, hi, Dr. Henke. No, there's a doctor here. Have a lovely day. And like hung up and like he gave me orders. So every once in a while you might have an on-site field physician. Meanwhile, offline medical control, these are your protocols, right? These are your SOPs, your GOPs, anything that we have written that we are allowed to do without asking Mother May I, okay? So know the difference between these two because there's almost always a question on the state about what are your offline medical control things.
Nicole, I just have a question about that.
Sure.
My department has a physician who responds to calls, but I was told medical control, Medcom, has priority over him. Like, we basically listen to him as a paramedic
Mm-hmm.
versus Medcom who are doctors, even though he's a physician.
He could be a physician, but he may not be a field physician. So you said Medcom, so I'm assuming you're in Nassau
Yeah.
County. So,
Yep.
Nassau County, in order for you to take orders from a physician, the physician needs to be an EMS field physician. My medical director for NYU is an EMS field physician, so he can pop up on scene and say, hey, do this. And he's authorized. There's actually a certification that Nassau County recognizes. So just because he is a physician,
Nicole, is that a REMAC certification?
it depends. If
Yeah.
you're in the city, yes.
You have to be certified by the fire department under REMAC. If you're not credentialed by FDNY, their orders mean nothing.
In the city, and that each county, each region makes their own rules for how they recognize doctors. So whoever the physician is who rides with you, Gary, he probably does not have that certification, which is why Medcom is still precedent.
Okay, next time I see him, I'll ask him about that.
Yeah, no, do.
That's also that comes down to licensing and insurance because it's part of what I do for my department is the administrative stuff, and they wouldn't be insured to practice in the back of your ambulance as a physician because there isn't as Nicole was saying, that if they don't have that certification, you cannot insure them as an EMS agency, and therefore anything they did as a physician or outside of the protocols of your agency would be a problem.
Yeah, and it would.
He had to take the paramedic exam to actually ride with us, but he's our medical director and a few other things.
Yeah, so basically,
Right.
and the thing is, like, as a physician, he doesn't need to do like the paramedic class for the most part. I
Right.
think he just has to like. There's a
He
few
just took the
things.
exam and that was it, basically.
Right. They have it's same with PAs, nurse practitioner. There we have a lot of people that ride with us that have higher levels of licensing but cannot practice. You know, I actually I don't know if you find, Gary, but I find some of them have a hard time practicing within protocols. They have a hard time remembering what they're actually allowed to do on the back of an ambulance versus, you know, an emergency room PA who would be able to go further on their own.
Exactly.
Well, that and anything that they do on their own in the back of an ambulance falls on their malpractice insurance.
Correct.
Yep. So it gets complicated, but that's a great question. Thank you.
Can we backtrack just a little bit? So in terms of documentation, I was taught that a PCR is literally just, because it's a legal documentation about medical care, that anything that's not about medical care should not be included in that. But if it's a certain type of scene,
So, and this,
are we...
yeah, this is the issue when it comes to, yes, it is a legal document, but what was the scene that you walked in? Like, how did you find the patient? Because even if you look at medical documentation for the hospital, they'll be like, patient was brought in by EMS with their arm splinted, right? So you're setting the scene of what was there. So if you say, you know, EMS responded, patient was found in a car. Okay, the car was it a crashed car? Was it a parked car? Like, you know, that makes a huge difference when it comes to what's going on with the patient. Patient was found at the bottom of the stairs. There's a trail of blood down the stairs, like they may have fallen, right? So you have to paint a picture because, like, if you're not telling anyone what happened, then you're not going to you're not going to be able to maybe justify some of the things that you did. So you have a patient who's sitting at the bottom of the stairs. They walked themselves down and sat there. Why did you put them in a C-collar? Well, I thought they fell. Okay, that's different than a patient who you found crumpled at the bottom of the stairs, bleeding from the face, who you put in a C-collar. It's a little bit protective, and it's a little bit providing information future healthcare providers to this patient, right? Nobody else is on scene. Nobody else gets to see what you see when it comes to being on scene. And that includes medical patients who are living in certain situations, right? So if you have a patient who's living in a hoarder facility, or who is living, or like a hoarder house, or someone who's living in unsafe situations, those people require social services, right? Those people maybe require some sort of assistance, and we are the only people who see that. I've told people, hey, there's really nothing wrong with this patient, but they cannot go back to the house they're living in. There's no heat, so documenting it's winter and there's no heat in the house, that paints a picture of like, why are we sending this patient to maybe, a rehab facility, even though they might not medically need it. As if you're doing it in good faith to help a patient or to paint a picture of the scene, you're not going to have an issue, because it's still pertinent to the patient, right? That's your social kind of history. And do they have family members? Do they have a safe place to live? That, yes and no. I mean, I will agree with it. Like, opinions, there's no place for opinions where you're like, I think this patient's not, is an addict. Is different than, upon arrival at scene, multiple used syringes found and crushed up pills were found on scene. You know what I mean? I think that it's just how it's being
Nicole,
presented.
you could also make like clinical judgment, so it's not an opinion per se, but a judgment call.
Exactly.
A lot of those cases where you want to be really specific on details is your suspected child abuse cases and or the crime scene. I mean, in the last 2 months, I've done 3 adult protective service calls. Just the patient in what we found in the apartment was unsafe for the patient to stay there.
Exactly.
So what I've noticed is if you always document and you always do right by your patient, the rest of it will flow. So if you know that, like, all right, like this, they have to go to the ER, they don't really want to go, and you document it the right way and you say the right things, you'll be fine. It's really, PCRs are very easy, and I know like sometimes they're like really annoying to write, but they're really not they're not like difficult per se, because if you just write what you saw and write what happened, it's not a big deal.
It's also come back to, when you talk about opinions, that the child abuse case, right? The child was afraid. That's not the best thing to write, because again, you go to court, you don't necessarily remember the call. What you need to write is the child was cowering in the corner, the child was, you write the reasons why you thought the child was afraid, whether they expressed to you that they were afraid, wouldn't make eye contact. There's things that you should document what you saw, as opposed to your opinion that you formed. I mean, clearly you're going to form the opinion, but that's I think the difference of, it's almost like, same with the medical, right? My patient had appeared to be having chest pains versus my patient was in Levine sign and tripod. I mean, it's the same idea.
Exactly. But let's save some of that for the documentation lecture on Monday, because otherwise we're going to have nothing to talk about. But those are also great questions. Well, there goes most of documentation. There you go. That'll be a short lecture. So QA/QI, the problem I have with QA/QI is there's no real good structure. QA/QI is not supposed to be punitive, okay? It's supposed to help improve patient care, improve documentation, and to identify problems with patient care before it becomes a big issue when someone gets hurt or dies, right? So the whole thing is, when it comes on my side, on the QA/QI, when I'm reading QA/QI things, I'm looking for issues. I'm looking for mistakes made with protocols. I'm looking for, like, oh, you have a patient with chest pain, like, why didn't you give them aspirin? Oh, well, the patient already took the aspirin. Okay, but why didn't you document that, right? You need to make sure that that's documented. And it also can kind of identify system-wide issues. So, for example, things that I've been noticing in my department right now is that they have very long on-scene times. And that could be because we don't have an accurate CAD system and the times are being skewed, or it could be that, we're spending more time trying to convince people to go to the hospital because everyone's still afraid that COVID lives there. So, Why? So these are questions that come up on the QA/QI. I have a lot of my guys will come to me and say, hey, can I follow up on this patient? That's fantastic. I have the ability to do that. Not all departments have that ability, which is kind of unfortunate. But I'll have people say, hey, can you look at this documentation and tell me what you think? So sometimes you have to kind of be aggressive for yourself to be better, right? You need to kind of understand that the first step in becoming a better patient care provider and being a better EMS provider in general is that you need to take some responsibility for your own actions. You have to be self-motivated. You have to be interested. If you're not, you're probably going to stay exactly the same and you're not going to be, you're not going to improve. Which, if you're pretty okay, then sure. But everyone has the opportunity to improve. You will always learn new things, and you will always learn new things from people you probably don't expect to. Always keep an open mind. So, in 1985, about 15% of our medical practices were actually based on solid evidence. Evidence-based practice. Research. 15%. That's terrible. Terrible. On average, it takes about 17 years for medical research to actually become medical practice. So things that we are doing today as standard were found to be researched 17 years ago. And when we talk about PTSD and stuff like that, like a lot of the practices that we do in EMS right now have been disproven in the 70s. We're way behind when it comes to evidence-based practice in terms of taking care of ourselves, which is terrifying. So just take that into consideration, right? You might be, if you're one of those motivated people who starts doing a lot of reading medical journals and stuff, the stuff that you're seeing now, anticipate coming down the pipeline in 17 years. Medical professionals are very difficult to convince that they need to do something different. They're like, I need to see the evidence. Okay, here it is. And they're like, it's a lot of work. So sometimes the things that we do don't make sense. For example, spinal immobilization on backboards, right? Yep. Wow, that was low. We were originally doing it because it was like, oh, we need to get this patient out of this burning car. And now it's like, nah, just strap him down. And you're like, no, that's really bad for your spine. Like, no one does that. So it's scary. Some of the most dangerous words that you'll ever hear. What's up?
I said standing takedown took so long to get out of protocol.
Like, why are you more or less tackling a patient? What? They've got sit. Please sit. Like, this is why there's so many back injuries in EMS, because we're like, let's do something weird. Well, I will say standing protocol was fun to practice when you were in the classroom. I don't think anyone's ever done it for realsies. Like, just have them sit down. Like, okay, there you go. Problem solved. So yeah. Anyway, some of the most dangerous words you'll ever hear. This is an old quote that I've now forgotten who said it. This is the way we've always done things. And this goes for across the board in everything. Research, education, pre-hospital care, emergency medicine. This is how we've always done it. That doesn't mean it's the right way, right? We are learning new things every single day, and we need to start incorporating those new evidence-based, good, best practices, because you know what? Like, let's improve patient care. Let's make sure, like, for example, they did a research study in Japan about head-up CPR, which we'll talk about later. Japan, right? Lots of tall buildings, lots of elevators. EMS is more or less being forced. Hold on one sec. EMS was being forced to sit patients up to fit them in the elevator to get them down to the ambulance. And they were finding they were having really good outcomes for patients in cardiac arrest, which you wouldn't necessarily think. Like, wow, you're sitting this patient up. It actually helps reduce the intracranial pressure because it's forcing the blood out of the head. So you're doing compressions and pushing all this blood into a patient's head. There's no way to get it out. So now you're, as you know, a patient in cardiac arrest, you have high levels of intracranial pressure and it does some damage to the brain. So people were having much better neurological outcomes with heads-up CPR. Another
no-
another
a
15
number.
years before that comes into practice.
There's a number of hospitals that are testing CPR in a semi-Fowler's or a Fowler's position right now.
That's fantastic. Well, see, but I'll have to find what date it came out, but that Japanese study came out years ago, like when I started EMS. So, like, wow, we're just getting to it right now. Or how about tranexamic acid? They've been using tranexamic acid, TXA, in the UK and Australia to treat trauma patients for like 20 years. Fantastic outcomes. It costs $80 for a full treatment with TXA. Do we use it? No. Why would we use that on massive trauma patients? It helps prevent clot. It helps maintain clots. But do we use it? No. $80. Too cheap. Let's make sure we use the $20,000, surgical, exploratory. The way we do medicine in this country is a little broken. But that's another conversation for another day. So, we talk about evidence-based medicine, which is pretty much making sure that we look at the entire patient and then make sure that what we're doing is in the best interest based on the research of this patient, right? So there's a lot of research going on, not a lot of pre-hospital care research, but we have to continually look at these things to see what we can do to be better to help our patients. So we actually kind of talked about this already a little bit, right? We have backboards. Any other things that we do as EMS professionals that you're kind of like, why do we do that? Where's the evidence?
Flying patients in general, it typically extends the transport time compared to actually reducing it, even in Suffolk County.
There you go.
Activated charcoal being in and out of protocol forever.
Yep. Like there must be a better way to do activated, or to not do or not do activated charcoal. I think I've seen it on an ambulance a grand total of once, and then it went out of protocol again. But good, yeah, there's a few things.
To be with, and they literally, whenever they knew Brian Sherwood would come to town, they would either put it in or put it out, depending on if it was in protocol.
Yes, no, yes, no. Yeah, maybe.
Nicole, what about syrup of ipecac?
Syrup of ipecac. Yeah, that's another one. Like that definitely went out of protocol about 10 years ago or so. It's still in the formulary, I believe, but I think that's mostly because no one's updated the formulary.
What about when they used to use the ammonia packets for the nose? To
wake people up? Yep. Yep. I think they still do that in the ER, actually.
They do. It's just a different, so a little bit of a different concentration now.
Yeah. So things I also learned, apparently your body has, when you're smelling, your body has multiple pathways, nerves that detect things. So like the ammonia isn't actually a smell, it's more of a burn. Just like your body, you should be able to smell smoke through a different pathway because it's pretty much your body going, alarm, alarm. So your body's pretty good at protecting itself, which is pretty wild. And we're going to skip that because we're not in person. It's my in-person stuff.
Is BLS CPAP in protocol in the city or no?
No. Oh, well, it depends on the hospital. I think Jamaica is, right?
I believe they are.
Wyckoff has 12 leads.
CPAP is agency based in the city. It's based on the medical director agency.
Hashtag BLS can do CPAP. Hashtag.
It's agency based in Nassau County, so it really
and
depends
there's a lot of
on
other
whether or
people
not
it's
you've
like
certified enough providers
whether or
in your
not
agency.
you actually can afford the CPAP. Yeah, it's always interesting. All right, any questions before you go on to the next presentation? All right, cool beans. Trying to figure out who's got the really terrible feedback. Yup.
That's probably me.
All right, so workforce safety and wellness, right? How do we keep ourselves safe? So going back to, it takes 17 years for good practice to get, or for good research to get into practice. There's a lot of different things that we've been told over the years that are not necessarily medically true. So supplemental calcium, strengthening bones. They give it to a lot of the elderly, right? It doesn't. Vitamin K2 actually is what helps put calcium from your bloodstream into your bones. When you have patients who are taking supplemental calcium without K2 supplementation, that just ends up lining their blood vessels as atherosclerosis and stenosis. You get enough of your vitamin D from sunshine. Not in the Northeast, you don't. Way too gray. We are not at an angle where that's really efficient. So vitamin D, let me tell you, vitamin D is an insane perk. Like if you're feeling a little drowsy and you're really not feeling great, go to the doctor and have them check your vitamin D. Usually it's like way too low. Fruit is good for you. Yes and no, right? So fruit's got high levels of sugar. Fruit as a natural fruit is good because it comes with all the fiber. But like fruit smoothies, not as good. That's just a sugar dump for your poor body. About 98% of upper respiratory infections, bronchitis, are viral in nature. So all you're doing by putting antibiotics on that is creating really highly resistant bacteria. High cholesterol, usually due to cardiovascular disease. Yes and no. High cholesterol and everyone turn on your cameras, show up. High cholesterol is definitely a contributor to cardiovascular disease. However, your inflammation levels. There's plenty of people who live all the time with super high cholesterol, but don't ever have a heart attack because their inflammation levels are very low. Acid reflux problems. If you take take your the GERD medications for GERD, you'll be better. Maybe yes, maybe no, but now you're eating and you don't have enough acid in your stomach to digest your food, so you're creating other issues. Sucralose. Sucralose kills more of your gut biome than antibiotics, as a sugar alternative. Reducing your sugar intake, just overall. Learn to drink black coffee like the rest of us. Sometimes the food pyramid, right? How many times have they changed the food pyramid in the last 20, 30 years, right? It's constantly changing. So do we really know what the good ratio for good health is? No, and that's going to be a highly individualized kind of thing. So yes, there are a lot of good practices in medicine, but there's also a lot of things that we don't necessarily do. Really, for the grand scheme of things, our physical well-being is dependent on a lot of different factors. Sleep. It's a huge one in EMS, or a lack thereof. There are plenty of people in EMS who work ridiculous hours, and like I've done it. Everyone I know a whole crap load of people who've done it, right? All of a sudden I'm gonna work a 16-hour tour, and then I'm gonna go home and I'm gonna change, and I'm gonna go and work an 8-hour tour at another job, and then I'll go home and sleep. That's not healthy. That's terrible. Shift work is especially overnights, has been associated with higher incidence of stroke and heart attack. Okay, a lot of issues kind of associated with that. Exercise is essential, and this is why at the beginning of every EMS class that I teach, I kind of tell people, listen, find something that you like doing that is a level of exercise. Go for a walk. You know, every day, if you just go for a 2-mile walk, you're putting yourself in a much better position. Smoking, don't do it, it's bad. Vaping, smoking, whatever, all bad. Don't do it. Body mechanics, lifting the right way. Oh my God. I cannot tell you the number of people who I see lifting patients in like just bizarre, not good ways. If you'd like to maintain your spinal column in one shape, learn how to lift properly, right? Make sure your body mechanics are well done. Nutrition and weight control kind of tie in together. You should be eating a balanced diet, right? You should be not overdoing it on the sugars and the fats and stuff. Vegetables are good for you. I've literally told I had a patient once, it was his 30th birthday, so he decided to go on a 3-day bender. And I was like, dude, you have to understand, you're 30 now. You can't party like that as much as you want to. You have to eat some vegetables. I really hope that was the takeaway that he got. Don't do drugs, just eat your veggies. So, right, so all of a sudden, we talked about our dietary guidelines. They've changed significantly over time. Fat's bad, fat's good. Sodium's good, sodium's bad. Don't do this, don't do that. There's so many different, now it's hot in here. There's so many different guidelines now. But when we talk about food and dieting is not sustainable. You should eat, a well-balanced meal, every meal, but you should also understand what your body needs. For example, if you're a highly active person, you're going to need probably a little more protein. It's good for your muscles. But moving on. If anyone's surprised about this, the vegetable intake is well below recommendation. Right, there's a lot of different things. Like, we don't necessarily eat great in the United States, and we also don't, in EMS in particular, right? People don't eat well. Oh yeah, wait, what's open? I'll eat it. I also always recommend that people pack food with them. Pack a big thing of water. Pack food. If you're gonna do coffee, or you're gonna need caffeine, do coffee. It's at least a relatively natural thing. It's not a monster that is packed with who knows what. So just keep that in mind. Right, Western diet. It talks about all these different. If you ever kind of go down the deep dive of how to eat, the Western diet is really bad, and it's actually really wild because you see a lot of these cultures, like the Aboriginals and like the Asian cultures, never had issues with obesity or high cholesterol, diabetes, high hypertension until the Western diet moved in. And all of a sudden they're drinking soda and they're eating fast food and all of that stuff. It's like directly related. If you eat whole natural foods, you're overall going to do yourself have a better outcome in general. Different types of fat that they talk about, right? So you have saturated fat, which is predominantly single-bonded fatty acids. This is your butter, coconut oil, red meat. Trans fat, which has been pretty much eliminated, or legally, I think they're trying to get rid of it, for the most part, has been eliminated from things. You'll see a lot of foods that are labeled as like 0 trans fats. This is... I don't even know if I want to talk about it. It's gross. That basically they've made this oil. There's usually the good fats that have been partially saturated. They add more hydrogen on it to make them live longer. And then you have your good unsaturated fats, right? So that's mostly like your avocados and nuts and stuff like that. The saturated fats and trans fats are the ones that really don't do you a good service in the long run. Eat with moderation. Don't eat trans fats. Your body makes its own cholesterol, so even if you eliminate all of the cholesterol from your diet, you're still going to make some. Your liver does this. But the problem with a lot of statin medications and stuff like that is your brain is like 25% cholesterol, like mostly cholesterol. So you see a lot of patients who are on statin drugs who start to have like brain fog, and then they take them off the statins and they start to improve. It's because you're now not making enough cholesterol, or you don't have enough circulating cholesterol in your system to actually improve or to heal your brain, right? So it starts to eat some of the cholesterol that makes your brain, which is what kind of leads to that brain fog. Your body is also like, hey, if you don't eat enough cholesterol, I'll make a little bit more. Cholesterol is a huge part of actually what makes up cell walls. So if you don't have cholesterol, you also can't necessarily repair some of the cells that have been damaged. You want to have good HDL levels, your high density lipos. The LDL, right? L for lousy. Lipoprotein. There it is. I'm having a Little brain fart. Your high density ones are good. That number can be improved through cardio. So go to the gym and jump on the Stairmaster. And that the higher the HDL levels are, the lower your LDL levels tend to be, because your HDL kind of eats the LDL. It's been described to me by a cardiologist. A number of different medications are used to kind of keep these cholesterol levels in either A in check or in B good ratios. There is a TED Talk on YouTube where she actually takes sugar and pours it out to describe how much is in a bottle of soda. And not like a big bottle of soda, like one 16-ounce, like single serve, small one. So 1 teaspoon of sugar is 4 grams. So if you look at this very French Coca-Cola bottle label, sugars here, you have 55 grams. So divide that by 4, and that's how many teaspoons are in there. So that's 11, 15, 13, right? 13 3/4 teaspoons of sugar. The problem with sugar is that it increases your inflammation levels, right? So the less sugar that you have in your diet, or less added sugar that you have in your diet, the less inflammation you hopefully will have, which means you have a less likely chance of having cardiovascular disease, cancer, and all the other fun things that we're trying to avoid. Sugar is addictive, much like caffeine and cocaine and all the other things that are bad for you. But long-term effects of sugar is that it actually kind of screws with your pancreas, and you have a super high chance of developing diabetes. We have really out of control levels of diabetes in this country at this point, because we start adding sugar to everything. Because all the processed foods, how are we going to get people to buy more? By adding sugar. There is a direct correlation between high dietary sodium and high blood pressure. There is a very small group of humans who are not affected by sodium and whose blood pressures are not affected by sodium. Very small group. But for the most part, if you eat a very salty meal, you will see your blood pressure go up. This is why around the holidays, we see a lot of patients calling with respiratory and cardiac issues, because they have some sort of underlying heart issue. They have, the holiday feast, which has a lot of sodium, and then their blood pressure goes up, and either they're in acute pulmonary edema, or they've triggered their CHF, or their ankles are swollen, or they're having a hard time breathing. It's, it's a combination of different things. Bland food, sometimes it's a little bit better for you. My dog is wandering around downstairs. All I hear is his
Going back to what you were saying about cholesterol,
Mm-hmm.
I know the cholesterol you get from animal products.
Going back to what you were saying about cholesterol, I know the cholesterol you get from animal products, so we're going to see a lot of issues with people who are
Here's a fun
vegans and
anecdotal story.
vegetarians
My
having those
mother
issues that you're talking about.
has been a vegetarian since she was a teenager. She's now 60 years old. She had 4 enormous stents put in about 5 years ago because her cholesterol numbers are through the roof. So it's a combination of things. So dietary wise, she does not have almost any dietary cholesterol intake. However, her liver has been like, yo, we don't have enough cholesterol, and has now upregulated the amount of cholesterol that it's making. So I was a vegan, or I was a vegetarian since I was 12. I became a vegan when I was 19, and actually about when I was 29, started eating meat and animal products again. I have noticed zero significant change to my cholesterol levels. I'm not really looking forward to the probably massive heart problems that I'm going to have in the future, mostly because I've really got horrible family history. But genetics do play a significant role. You have to keep your inflammation levels under control to kind of reduce your risk. That answer your question? So yes and no. So like, for example, like what's his name? The Biggest Loser personal trainer.
Yes.
He had a massive heart attack in the gym, right? You wouldn't expect this guy, he's in great shape, right, to drop from a freaking heart attack. Genetics do play a lot of a role that you don't necessarily control. You aren't able to control. Mhm.
The other thing about The Biggest Loser is that it's
Yeah.
a rapid weight loss. So you lose weight
Yeah,
like
but
that.
but this was
your heart's
the
already
trainer,
messed
the
up.
guy
Like,
who
you're off to a really
he
bad start.
you know, I'm a personal trainer. I've been doing this for years and years. You're like, oh, fantastic. You should be in good shape. Boom. Like the treadmill took him out.
I believe the average healthy weight loss per month. I mean, I believe the average
Mhm.
healthy weight loss per month
guys
is 3 to
want
6 pounds
It
max.
just so happens that if you guys want, actually, it just so happens that I went to college for nutrition, exercise, physiology. I like dual majored. So if you guys have random questions about that stuff, hit me up. And
So
healthy
can we do
weight
this while we're
loss is
surfing?
1% of your body weight in fat a week.
Is there any?
So it's like 2 pounds a week, essentially.
Is there
Depends
any?
on what you say. It's 1%.
Yeah.
But
And
if you
by the
guys
way,
want not
right.
to change the subject, don't veer off. But offer's
Bye.
there. It's on the table. I'm here for you. And now I'm going on mute again.
Dang. And it's also important to note, and I'm sort of at that age where I'm starting to see some of my friends. I had a very dear friend who died at 39. Very, very healthy, exercised every day.
Yeah.
You know, those kinds of things are often just genetic. I mean, there's not much you can do. In
Very
fact, I
true.
think the
So,
younger
and
you
then
are
we're
when you
talking
have a
about
heart
the
attack, the
cardiology,
less
but
likely you are to
older people tend to do really
survive.
well because their tiny little blockages start to develop, like those tiny blockages. Your heart creates what's called collateral circulation and kind of builds new pathways around those blockages. When you're young, you don't have those little blockages, so there's no backup plan. So if you pitch a clot into your heart, you're done. Like your heart's just it can't go to the like quick detour route to get blood to that heart muscle. You're gonna have a really poor outcome.
And they treat my husband's father died at 32 of a massive heart attack. And they treat my husband's father died at 32 of a massive heart attack. And they treated my husband for his entire life and continue to as a high risk
Yeah.
cardiac patient, even though he has zero risk factors, is very active and whatever, but they still treat him. He still gets tests and all sorts of,
smart.
they have always treated him as a high risk cardiac
Genetics play a
patient.
huge role that as I said, you'll never actually be able to appreciate until you're 32 years old having a massive heart attack. It's wild. So exercise is really fantastic. As I said, find something that you like doing and do a little bit every day. I'm not saying go, get on the Peloton and ride for 2 hours, but do a little bit something because it's really good not only for weight control, it helps you sleep. If you exercise first thing in the morning, it actually lowers your cortisol levels so that you are less stressed overall. It helps with your mental capacity because it increases the blood flow to your brain. And it also serves as a coping ability, especially in a high risk, high stress occupation such as EMS. You need an outlet to cope. Like, it could be almost anything, but it shouldn't be detrimental to your health, like drinking or smoking or whatever other vices that might pop up. So exercise, always good. Smoking, number one cause of preventable disease in the United States. It causes all sorts of issues, peripheral vascular disease, lung cancer, et cetera, et cetera. I don't understand why people even start smoking anymore. E-cigarettes are an issue as well. They're very high temperatures, so they cause a lot of blebs and stuff like that, causing popcorn lung, which is, again, disastrous for your lung health. We talked about this a little bit, right? Your shift work screws with your REM cycle and your circadian rhythm, so it puts you at a high risk of high blood pressure, cardiovascular disease, cancer. Everyone has kind of their own unique circadian rhythm, so sometimes it's going to be, it'll be sort of like this, where your deepest sleep is at 2 a.m., where you start to wake up with the sunrise around 6:45, but not everybody is here. There are people who are natural night owls who shift work isn't an issue for them because that's their normal time. Usually the circadian rhythm for most people kind of sticks to this general clock. However, there are some people who might be off a few hours either way. So just things. Lift with your legs, not your back. Even better, lift with your firefighters, not your back. You want to. No pun intended. You want to make sure that you keep all of that, any weight close to
No
your
pun
body.
intended.
Pushing is easier than pulling. Working smarter, not harder. Always good. But you make sure you have a plan. Anyone who works in Queens, you'll see some of the really curious staircases that have been built, where they have weird spirals, uneven steps. Just be careful. Like, if you are in any way, shape, or form going to be moving somebody up and down stairs, make sure you kind of look at the stairs first. Also, make sure, and this is a huge Queens thing that I've seen, please make sure that if the patient or their family has a million pairs of shoes on the stairs, that those are moved before you move a patient. For some reason, stairs equal shoe storage in most of Queens. Self-care is important, and not just like self-care like I sit in a bubble bath and have a glass of wine. Like, do something that may be good for you. Read a book. Make sure you're doing something to de-stress, and that kind of, reduces whatever anxiety or issues that you might be feeling. Again, high risk, high stress occupation. Set yourself up so that you don't have to worry about any issues in the future. And this also kind of revolves around making sure that if you do have a tough job, like, you maybe take a break. Like, a lot of people, you have PTO. I can't tell you the number of EMS professionals who are like, I've got like 180 hours of PTO. That's fantastic. Take it. Like, if you're having a hard time or you need a break, take your PTO. It's not going to do you any good if, you're out of the job because you hurt yourself or you're, mentally not good. PTO is there. It helps prevent mental burnout. It helps prevent physical burnout. Please use it. Okay? There's a number of different things, factors that are incorporated into what consists of stress. And stress isn't always necessarily going to be a negative thing. For the case of this lecture, obviously, we're talking about negative stress. But there are a lot of different factors. Issues on your job, if you're fighting with somebody, if you're fighting with a spouse, if you are dealing with an injury or loss or some sort of major life events. Major life events don't necessarily have to be a negative thing. Maybe you're planning a wedding. I did that a couple years ago. That was relatively stressful. Maybe you're going to school, like paramedic school, right? It's a good thing at the end of the day, but that doesn't mean it's not a new stressor that's going to contribute to how you feel at the end of the day. Nope, too much enthusiasm. Different types of stress, and you see this, this tends to be a test question a lot. You have acute stress, right? That's the, oh my God, we're going on a call, it's a pediatric arrest, I am stressed, okay? Then you have the delayed stress, which is, okay, I did a pediatric arrest the other day, and now I'm really kind of feeling like a little stressed about it. I'm not, did we do the right thing?
Delayed PTSD?
Delayed can turn into PTSD if it's not if you don't accommodate it, right? If you don't address it right away, it can turn into PTSD. Delayed responses are also stuff like you wake up 2 days later, like, damn it, I didn't put a pulse ox on that patient. I really should have put a pulse ox on that patient. But if you then dwell on it for a long time, yes, that can turn into PTSD. If you say, okay, like, that was a thing, we learned from it, we move on, that delayed response is not necessarily going to be habituated into PTSD.
Well, that's what's good about after a major call. Well, that's what's good about after a major call.
Yeah,
to have an after-action review done.
Yes and no. Because
Good way to
sometimes
start to
this
identify
delayed response
who
can also be
is
months
having
later.
issues.
So doing it right after the call can be helpful, but at the same time that I feel like we use that as an excuse to then not follow up with people like 3 months, 6 months, a year down the road. Then it's just be like, oh, you're fine. We talked to you right after it. Okay, but like, that was here in the acute stage. That didn't help me here in the delayed stage when I was starting to feel a little more stressed. Then on top of that, you have cumulative stress, right? Every single job that we go on, we have like certain levels of acute and or delayed stress. Cumulative stress is the additive properties of all of your stress coming together, right? And that's also contributes to your overall stress. So non-job related, you got a parking ticket, you have to pay a bill, you're didn't get the overtime shift that you were depending on this week, or there's so many different things, right, that contribute to your overall stress, that we need to make sure that we address. You can't just push it aside, push it aside, push it aside. Not healthy. Even if it's something small, like writing down a list of all the things you have to do so that you have a physical representation of, what's stressing you and how you can manage it, okay? Social support. Number one way to prevent PTSD is social support. Having someone to talk to. It doesn't necessarily have to be someone in EMS. You can have somebody who, a family member who is just a good listener, right? But social support is important. Do not isolate yourself.
Was I misunderstanding you with what you said from my comment?
Was I misunderstanding you with what you said from my comment posted in the chat?
Too much way too fast.
Like, are we saying that it is more likely if you lose too much weight too fast to get a heart attack?
Oh, you're bringing it way back. I don't know. I didn't even see that. Bring that up at the end. I'm not sure. I have to readjust it.
Yeah, you have to remember that heart is muscle. I actually had an
Yeah,
uncle
James,
who
you're
was
gonna die.
anorexic and died of a heart attack. Yeah, you have to remember that heart is muscle. I actually had an uncle who was anorexic and died of a heart attack because when you don't supply your muscles with enough nutrition, yes, you can die.
It's overall not eating is, more damaging than eating more.
I just did portion control though.
Let's finish this and we can circle back to that. There's a number of different ways that people can respond to an illness and or an injury. It obviously, we see a lot of these when it comes to patients and their families who are having an issue. Fear, confusion, anger, anxiety, depression. We also can have a lot of these responses as well. This doesn't just apply to our patients. Again, some defense mechanisms that are obviously seen. A lot of our patients will do, regression. Regression is really very commonly seen in children, right? You have that 5-year-old who might have gotten hurt and all of a sudden they're sucking their thumb again. Their parents are like, he doesn't suck his thumb. I don't know what's going on. I feel like projection is more commonly seen in adults, right? Where we start to blame other people for our problems. Denial also. Adults are super good at denial. This isn't happening. This isn't real. It's okay. It's fine. We're moving on. Right? So all different ways that we could deal with that. Burnout is the number one way that we lose people in the healthcare profession, not just EMS, but also physicians and nurses. A lot of the times burnout starts with a negative work culture. Okay, so you have, issues in your place of employment that kind of don't make you feel welcome or excited to go to work, which is right here, like a desire to go to work. But other things start to take a toll on you as well. I don't know if you guys can hear my dog, but he's barking at nothing. Right, so you start to kind of get fatigued, a little irritable, a lot of negative attitudes. You don't want to do your job. You might have a hard time sleeping. There's a lot of things that burnout can do, and it kind of is what ruins people for, especially EMS, right? Especially you working in a busy area and you're like, you know what? Like, I don't want to pick up this drunk anymore. I just don't want to do it, right? You're like, come on, dude, get in the ambulance. Let's go, right? Great sign of unfortunately, a great sign of burnout. This also can start to contribute and trickle over into personal life, where you start to lose interest in your hobbies. You might have brain fog. You might get sick. And this is where I say, hey, use some PTO, get a little distance. Right? I think we've all felt this way. When you shouldn't be on duty for 48 hours. That's just too long. You need a break. So talking about PTO, on average, American workers are not doing their 40 hours a week. They're doing it almost close to 50. most people work well over. In EMS, it's sort of becomes a strange badge of honor. Oh, I worked 120 hours this week. That's not a good thing. Like, yeah, that's great. Look at you. Your paycheck's gonna be great. Uncle Sam's gonna appreciate you hardcore. But that's not helping you. That's not helping your family. You know, they need someone who's present, and they need someone who is like physically capable of being like participating. Can you imagine? 2016, 662 million vacation days went unused. Use your PTO, people, because when you leave a job, that PTO's gone, right? You may get paid out for it, but at the same time, use it. Why are you gonna wait for that payout check when you could use it now and feel better overall?
So I've actually noticed that I feel like a lot of people after COVID are more burnt out and more
Oh, yeah.
negative and whatever. Like a lot of nurses lately have been awful. And meanwhile, during COVID,
Yeah,
everybody was like, "Oh, we
I
have
think that
family,
you can
whatever."
only
But
keep
like now,
up that
everyone's like, "No,
that
like, no."
you know that strong saving face vibe for only so long before you get tired. Like, but people aren't taking PTO, or people aren't able to take PTO, or don't feel like they're in a position, and that kind of also kind of comes back to the American workforce, where we try to get by on the minimal staffing requirements possible, right? Okay, well, you are leaving us short staffed. That's not a me problem, that's a you problem, right? If you're not going to staff the department effectively, that shouldn't affect me. I should be able to take my PTO when I need it. This isn't about you as an employer and what you're supposed to do. You're supposed to staff the department effectively. I feel like we've also lost a lot of healthcare providers after COVID, in so much as people just leave the profession because they don't want to do it anymore, because there was a lack of support throughout COVID. Yeah, okay, the 7 o'clock clap was nice, but like at the grand scheme of things, was what you know, you still have people who aren't wearing masks, and you still have people who are just kind of willy nilly doing whatever. Um, it's insulting. So you have a lot of people who are experiencing significant burnout, and I can't imagine the PTSD that's developing from this, because no one had a time to decompress. It's been over a year of just go, 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 foot on the COVID accelerator. People are done. People need a break, but no one's hiring because, oh, we're on a hiring freeze, we lost so much money, and it becomes a systemic issue. Unfortunately, it's a really good point you bring up. Death and dying, right? We have 5 stages of grieving: denial, anger, bargaining, depression, and acceptance. These can all happen simultaneously. They don't necessarily have to happen in order, and they don't necessarily have to happen right away. This is a process that every person experiences uniquely. Sometimes people are kind of okay, right? They might be here at the acceptance stage, and the next day they're back at the denial. Totally normal. It's a process. I'm not going to play this video because it's a bit long. I will send you the link to it, though. This talks about how we as healthcare providers need to be better at dealing with death. We kind of build up this wall in our profession, that we don't necessarily, like, someone passes away and we're like, I'm sorry for your loss, and kind of take off. Sometimes just having a little bit more compassion and empathy is kind of essential. But I'll send you guys that link in the follow-up email to class. I think this. Yep, that's it. All right. Cool, cool. Thoughts, questions, concerns? All right, cool. Next lecture, let me just pull it up real quick. Public health. Are you going to be like that, Google Chrome? Hold on, it's doing a thing. Come on, share button. Let's see what it pulls up, because I have 3 Google Chromes open, so if you see my email. Sorry, not sorry. Oh, there we go. Come on. Clearly my computer needs a little more coffee today. So EMS, we kind of fit in this weird part of public health where we have the ability to help prevent public health issues as well as kind of dealing with public health issues as they happen. Hi, Hansa. So this might be a little outdated. I think they might have updated it, but here's some of the common causes of death in different age ranges. You'll see here as you start to hit your 40s, coronary heart disease is really out to get you. Stroke also up there. Right, various types of cancers. As you look at the young children, right, you've got mostly accidents and stuff like that. Cancers kind of fall in here at like 3rd and 4th for the younger age groups. So just some things to take into consideration. There's a lot of things that can kill you. Heart disease and cancer. It'll kill you super fast. The flu is still on there. I wonder if that's updated. That's definitely not updated for 2020. And women, same thing, right? Heart disease. Once women hit menopause, your risk for dying from heart disease equals or surpasses that of men. Estrogen is a highly protective hormone. So while you're still menstruating, it is super helpful in keeping you safe from a lot of that. Morbidity and mortality, we talk about this a lot, not only in public health, but in hospital settings, right? They talk about, they do M&Ms, right? What caused the morbidity and or mortality for a patient. Morbidity are the non-fatal injuries, whereas mortality are considered the fatal injuries. We deal with both, right? In EMS, we have patients who have horrible accidents and they fall into the mortality range, and we have a lot of patients here who are non-fatal. We end up bringing to the hospital. In each community, the injuries are different depending on what community you're kind of working in, but these are the most common when it comes to intentional injuries, right? Suicides, homicides, rape and abuse, assault and battery. This is like most of the most frequently seen intentional injuries. Unintentional MVAs, which just I've seen the way some people drive. I would put some of these MVAs into the intentional category. Poisoning, again, could fall into the intentional category, right? You have a lot of people who are trying to hurt themselves with the medications, drugs, etc. Falls most of the time are unintentional, right? The elderly population tend to have a lot of issues with being steady on their feet. And then children have their own kind of special category where drownings in particular are really high risk for them. There's a lot of positive feedback in terms of getting children swimming lessons early to help prevent drownings. Kids and firearms, right? I think there was very recently a child who found an unsafetied loaded gun in the house and shot either himself or a friend. Kids in vehicles, always a problem. Kids in falls, and kids sometimes doesn't even need to be like a fall from height. Like a fall into a sharp coffee table can do some pretty good damage. The elderly are always going to be at more risk for morbidity and mortality than any other population because they commonly have comorbidities, right? So cardiovascular disease, diabetes, potentially some sort of infection, high blood pressure, all of these things contribute to kind of reducing their overall health status. So, and also the medications that they're on, right? We talked, I think this is the other class. One of the most dangerous patients you can have is a patient who's taking a beta blocker and a blood thinner, right? So grandma's got high blood pressure and AFib, so she's on metoprolol, and she's on Coumadin, and then she falls and breaks her hip. that's going to be bad. She doesn't have that compensatory mechanism because the beta blocker is blunting that tachycardia potential. And now she's bleeding freely because she's on Coumadin. Not good, right? Hip fractures are extremely deadly for the elderly. Most of the time, status post fall, you have a high mortality rate of about within 1 year. Most of the time, it's due to a secondary complication. It could be an infection. It could be failure to thrive. It could be that they are no longer able to live at home and now they're discharged to a nursing home and they pick up community acquired pneumonia or something to that effect. Or, nursing homes aren't exactly the safest place to be in the world for the elderly. You have a lot of people who potentially work at a nursing home who should not be tending to another human being. And then you have a whole group of the elderly who will die within 1 month because they never actually recover. The problem is also you have a lot of elderly who then lose kind of the will to live after they've broken a hip because they're no longer able to participate in activities of daily living that they used to. Okay, just issues. Things that we can do as EMS providers is we kind of have some of these opportunities to either do primary prevention or secondary prevention. So primary prevention is when you're keeping an injury from ever occurring. So this is, when we've put a kid with a bike helmet, right? You give them the bike helmet, right? You're not going to get hurt. But when you're going to perhaps a home of a patient, maybe that's moving a loose rug out of their path so they don't trip and fall. And then you have secondary prevention, which is reducing the effects of an injury, which is when, they're like, all right, we noticed at this intersection that there's a lot of car accidents, so we put in a traffic light. Okay, that's your secondary prevention, so it's going to prevent other issues. And then we have this opportunity here for teachable moments, which sometimes is good, sometimes is bad, really depends on your approach and your rapport with the patient, because sometimes people are not necessarily willing to hear it. But this is when a patient has a minor injury secondary to doing something sometimes stupid, and you go, you really need to wear a helmet, right? It's that 16-year-old who fell off their bike and broke their wrist. You should be wearing a helmet. You broke your wrist this time, but next time you might give yourself a bad concussion. You don't want to be a weird drooling vegetable for the rest of your life, right? Those are your teachable moments. Again, maybe not calling the person the vegetable, but sometimes you have to be forceful.
Community paramedicine? Was
Sort
that a part of community paramedicine?
I feel like community paramedicine has a little bit of primary and a little bit of secondary. So usually in the community paramedicine structures that currently exist, a lot of it is due to, a lot of the patients that they see are congestive heart failure patients and fragile diabetics. So those are the ones who they're trying to keep out of the hospital. So they're reducing that effects of an injury or disease, right? So they're making sure that they have their prescriptions filled, that they're taking their medication properly, that they're using Mrs. Dash instead of salt, right? Stuff like that. So that's here. But it also falls into a little bit of primary prevention because as a community paramedic, being invited into someone's home that no other healthcare professional is necessarily going to see. So that's, hey, let's get you a handrail for the bathroom so that you can get up off the toilet and not fall into the Bermuda Triangle of the toilet tub area. So yes, it does have some of the preventative kind of factors to it while also being kind of helping in the back end as well. The patient already has an issue. You're just hopefully keeping it from getting worse. 4 E's of prevention: education, enforcement, engineering, and economic. Education is when you're kind of telling patients hey, don't do that. That's not a good move, right? Not always successful, right? A lot of times you have people who are like, I don't care. You can't tell me what to do. But you can try. Enforcement, we aren't here. This is your legislators, right? They're the ones who are requiring safe practices. So a la COVID, right? You should be wearing a mask. Engineering, I don't know if anyone's driven in any of the roads in Long Island recently, but they're replacing all the guardrails. That's your engineering part of prevention, right? So you're changing how the environment looks to prevent things from happening. So when we put in roundabouts, you're trying to slow drivers down, traffic lights, stuff like that. And then economic is monetary incentives to reinforce safe behavior. So this is when you have those bike helmet drives at the local ambulance corps, right? You come and we'll give you a helmet, or come get your child seat properly installed in your car and we'll give you a Dunkin' Donuts gift card, right? Sometimes people need some sort of incentive to actually do the right thing. This is in your textbook, the Haddon Matrix. There's 3 components to ensuring public health: the host, the agent, and the environment. We can control most of these things, but there are some things that are out of our control. When you are developing a community prevention program, you should assess what your community is. I feel like a lot of this has either A, already been done, or B, has been put on pause because of COVID. But you need to conduct a community assessment, right? So what's the issue in your community? Does your community not have bike paths? Does your community not have a safe spot for kids to play? What can we do to make it safer, to make people, not have accidents and injuries? Setting goals and objectives, planning and testing interventions, and then seeing if implementing it and seeing if it works. Anybody have any ideas? If you had to do a community program, what would you, as the ambulance corps, what would you institute in your area?
General first aid and awareness to the community.
Okay.
General first aid and awareness to the
All right, so
community.
like basic bleeding control,
Especially primarily for
CPR
kids and elderly.
training, placement of AEDs, right? Stuff like that. That would be very helpful in a lot of communities.
A lot of Narcan.
A lot of Narcan, but not too much Narcan. We're going to talk about that in pharmacology.
Narcan.
Just enough Narcan.
We've been on a nutrition program.
Say that again?
We've been on a nutrition program. So we've been doing, we do a nutrition program, and we always open our doors to collect things like fresh fruits and vegetables and other things that like food pantries can't collect. So yeah, so we do that with the church, and they store everything, and we actually have provided throughout COVID like fresh milk, eggs, and assorted thing of fresh vegetables for the families in our community that are
homeless shelters,
identified
right?
as being
So
in need.
battered women's shelters and stuff like that, places where people are trying to start over. They fall into this unfortunate cycle where they might be receiving food aid, but they can't have fresh fruits and vegetables and milk and stuff like that because of refrigeration issues at a lot of these places. So all of those really good foods that you should be feeding to these kids and like to people in general becomes like this little bit of a food desert because there's no refrigeration capabilities.
That was the biggest concern that we had identified at our food pantry was that they. That was the biggest concern that we had identified at our food pantry was that they didn't have refrigeration. So that was something that we coordinated during COVID when we were being crazy.
So Beth, I think that's actually pretty cool, but how are you on a beach right now?
WebEx has virtual backgrounds. This is something that I have discovered is critical. I do public meetings. I'm an elected official, so I do public meetings all the time. And I don't really want the 5,000 people who are watching my meeting to see the inside of my house. So
okay, gotcha.
How do you put a
there's
cool
a
background
carrot
on?
next to your video thing. It says stop video. You can find a virtual background there. There's a carrot next to your video thing. It says stop video. You can find a virtual background there.
No carrots for you.
Yeah, I don't have that. Anything that'll just cheer me up a little bit. Anything that'll just cheer me up a little bit.
Are you taking Tylenol or no, Mike?
Drive Valium, but I don't know how to
Are
get it
you
from
not
the
able to
pharmacy,
drive?
so I'm trying to figure that out now.
I drove home last night, and it took me like 2 hours to get to my
I drove home last night, and it took
Ouch.
me like 2 hours to get to my house from Yonkers, and I live 20 minutes away. So I had to keep stopping. So, yeah, it's just
They
it hurts
have
to like press the
which
brake,
pharmacy
and
are
it
you
hurts
using?
to
Because a
steer
lot
the
of them
wheel.
have whatchamacallit, delivery services.
CVS.
I do believe that they have delivery services, so you might be able to
CVS.
Get that.
Sometimes they won't deliver narcotics, though.
This is true, but you can always try.
Sometimes they won't deliver narcotics, though.
Do you have no one home to
I was
get it
gonna
for
say
you?
narcotics is charity, so I don't know about that.
Do you have no one home to get it for you?
And again, narcotics, they
I
might
do,
not.
but my dad's working, so I have to wait
They
till
might
he finishes
not
work.
let him pick it up.
I need to be there for it.
You might,
Oh, like I
but
need.
if he's your
I
dad, you
need
should
to be there
should
for
be
it.
okay.
Yeah, you have
parents
to show
should
your
be
ID
able to pick
usually.
it up for you. Same last name. Yeah, the ID right. usually Your parent should be able to pick it up for you. Same last name. The ID usually is effective. I've
They
done
got
it
the
for
beach too.
family members.
Oh, that's so unfair.
So awesome, isn't it?
It is.
And then you only see your
Oh,
face.
that's so unfair.
But you
So
can't move
awesome,
too
isn't
quickly.
it?
That's the only problem.
And then you only see your face, not everything else.
Mike actually looks like he's on the beach right here. He's got a little,
Poor
little sun
Mike.
going
It
on.
is. It
Sun
is.
I
vibe.
wish I was in the beach right now. I can barely roll over. Ow. I wish I was
All right,
in the
don't
beach
laugh
right
too
now.
much.
I can barely roll over. Ow.
I actually think it would be
True.
kind of cool if we all had the same background because we'd actually feel like we were all in the same place.
But I wasn't invited.
Yeah, I'd just be
to the
looking at you
beach.
guys jealous.
All right. If you go to the little ellipses on the top right of your screen, it'll say virtual background, or change your background, and then you could go from there.
Mine won't let me. I don't meet the requirement.
Yep,
Mine won't let me. I don't meet the
That's
requirement.
depressing. All right, well, no good for you.
The system
But I
requirements
will
won't
give
allow
you
it.
lecture number 4. Go, go. There we go. Medical, legal, ethical. So let's do a little case study. So your dispatch information. Your EMS is requested to respond to a private residence for a female patient with an unknown complaint. The patient had originally called 911 complaining that her mother was trying to break down her door. PD is already on scene, claiming that this is multiple times that they've received this complaint from this patient, and that the scene is now secure. So you are in a 2-story home with varying states of tidiness. In the front, it's like a mullet. The front is clean, the back is a mess. Patient has self-barricaded and but voluntarily exits when EMS has arrived. Patient is 64 years old. She is a female. She is disheveled and agitated. Meanwhile, the patient's mother, the one clearly breaking down a door, is a frail-looking 96-year-old sitting in the front room in a rolling walker. No other occupants in the house. It has been searched. PD claims that they've been to the home hundreds of times. Frequent caller. Patient denies any and all medical history, but claims that she would like to call her husband, Prince Charles. And she is the 96-year-old female's sole caregiver. Any medical, legal, or ethical issues that you've identified so far?
I actually had a poll similar to this yesterday. I mean, similar in the fact that there was like an older. I mean, similar in the fact that like it was like an older person being cared for by just somebody that shouldn't be caring for them in general. And we actually had there was adult protective services like caseworker there who, but might I add, it was absolutely useless.
I'm sure.
And massive amounts of money are being wasted on that.
Did you ultimately
right
transport?
We did ultimately transport from Jamaica to NYU Tisch in the city. We did ultimately transport from Jamaica to NYU Tisch in the city. Yeah, 96-year-old woman got diagnosed with 96-year-old woman got diagnosed with stage 4 lung cancer, and her family didn't tell her. So like they like pulled us aside into the other room, and they're like, yeah, she got diagnosed with stage 4 lung cancer the other day, but we haven't told her. You can't tell her.
So ethically,
that was like a really like sick.
That's complicated.
Very.
Wow.
Yeah, and the adult caseworker person was like on board with not telling and the adult caseworker person was like on board with not telling the patient, which blew my mind.
I had the same thing happen to me with a different cancer like a couple months back.
Well, the problem then becomes, is it
Yeah.
going to make the
It's like
well-being of the patient worse in your
Yeah.
care and all that stuff? So I get it, but
You're a human with cancer.
I get the stress, like we
I
don't want
get
to
it,
give her
but-
stress or anything like that, but that's
it doesn't change the fact that her family sucks. But
yeah.
it doesn't change the fact that her family sucks. But
Yeah.
no, it's not.
What comes into question, is it your place to tell her that?
No,
But
no,
still
it's not.
complicated.
No, it's their place to
regardless.
tell her.
But strange that the doctor would allow that. The doctor who diagnosed would only speak.
Very.
Strange that the doctor would allow that. The doctor who diagnosed
Yeah,
would only
that's-
speak.
The doctor definitely did not seem on board with that.
I find it strange, but I'm talking about whoever diagnosed her, because whoever diagnosed her obviously told the family and not her, and then you
in
get
which
into
case, I'm wondering
questions
if there
of
were
guardianship and legal capacity and other things.
healthcare proxies and all that other stuff already in place, and if the patient maybe had some sort of underlying, cognitive issues, right? Because that's always complicated.
She was like a pretty sharp 95-year-old.
But the
She was like a pretty sharp 95-year-old.
But the question is, wherever she went to get medical treatment, where she got diagnosed, why did
There was from NYU.
Right, but why did that particular doctor who diagnosed her speak to her family without her present? Because
Yeah.
that would normally not happen with somebody who was within legal capacity assessments to be making their own decisions. So, if I went to the doctor and my husband was there with me, they wouldn't kick me out of the room to give him the diagnosis, right? I'm experiencing this with my children who are turning 18 and becoming adults, and
Yeah.
I'm now being asked if I can stay, or they're being asked if I can stay in the room when they're being given medical information. So it's just very
family.
strange
Yeah,
to
that
me
is
that
very,
whoever
very curious,
diagnosed
and
her
that's why
would
I'm wondering, she
only
might have been
help
very
the
sharp
family.
when you dealt with her. Maybe there's some sort of documentation of the dementia somewhere, because that is like the easiest and fastest way for, like, I feel like medical professionals, and this is really cynical, but to kind of take away the rights of the elderly is like, oh well, they have a history of dementia, we're not going to talk to them. But that quote unquote dementia isn't necessarily substantiated, because it's so easy to be like, oh, they're confused. But are they?
Yeah, you see that a lot with the patient where you see that a lot with the patient where you'll go in, you'll go to speak to the patient. I'll be like, hey, I'm Anthony. I'm an EMT. What's your name? What seems to be the problem? And then all of a sudden, like the daughter, someone comes in and is like, well, they blah 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 blah. And I'm like, hold on a second, can she speak? And then all of a sudden, it's like the person's completely A&O, and yet there's another person just stepping on them and not letting them talk. It's very frustrating. A lot of times, I'll be like, listen, I'm going to talk to her until when she doesn't answer a question the way I want it answered,
Yeah.
then
And
I'm going to come
culturally,
to you
that also
secondary.
happens a lot.
I'm trying to speak to this person, not you right now.
Yep. Yeah,
I was
and
gonna say,
also I've
nursing
seen it
homes, that
with
happens all the time because they
very
don't
devout
care.
Middle East. Yep, very devout. Like, you call for a female patient, you're
Yeah,
trying
like
to
a
talk to
Middle
the patient,
Eastern
and
family.
there's a male representative.
Yeah, am I allowed to go to the hospital? Yeah. Right now? She's
Mhm.
like, yeah, am I allowed to go to the hospital right now? Yeah, no, I've seen that.
So,
I actually had that
in this
happen.
current
when I was, like,
scenario
over by Elm.
that were just presented, what are some of the medical, legal, and ethical issues that might exist? So, first of all, how many patients are there? Two.
There's two.
Two. Okay, good. How would you proceed?
Two.
Like, what would you
There's
want
two.
to do beyond just like patient care? What would you want to do for both of these patients?
Well, have to assess their basic mental status, see whether or not.
Well,
Have to assess their basic mental status, see whether or not how accurable, how well the daughter's caring for the mother,
Okay,
how well the
good.
mother can actually take care of herself, and determine what's going to need to happen with both of them.
Sorry?
A lot of times,
So from a PD
if I'm in a
standpoint,
situation like this, I usually would just err on the side of if I get in a situation like this, I usually would just err on the side of, hey, let's just transport both people, get them both checked out, separate rooms, blah, 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 and then explain to somebody, hey, listen, this is what's going on. Can we get a social worker in here to investigate this? And just have them transported and separated. I've even done it with a child before where like I thought something, and I was like, hey, let's both, we're going to go, but in separate ambulances. It's a technicality,
Okay.
blah, 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 blah. You're
Yeah.
going to the same
Alright,
place, but you'll get checked as two different patients, yada, yada, yada.
So, things that we usually tend to end up dealing with are civil suits, right? Which is falls under tort law. We have to worry about liability. Who is the one responsible for whatever has happened? So we need to provide care to a standard that any other EMS professional at the same level in the same area would provide. So as a paramedic in New York City, I would do this, this, and this, and that is our standard of care. If you do not provide that level of care, you are liable, or potentially liable, depending on if some sort of issue has occurred. Plaintiff versus defendant. The plaintiff is the one who is pursuing litigation. They're the one who they have the burden of proof, so they need to be the ones who establish the fact that some sort of issue has arisen, and the defendant is the one who is liable for it. Defendant is obviously the one who is defending against the suit. Punitive damages is any sort of monetary award for physical suffering, anguish, medical bills, loss of earnings, etc. On the other end, we have criminal prosecution, which is action taken by the government against someone who believes that they have violated some sort of criminal law. The issues that we deal with primarily in EMS are assault, battery, false imprisonment. Yes, go to the bathroom, Mike. Kidnapping. So, in regards to assault and battery in New York State, they are one and the same. They are kind of grouped together. So if you're being charged with assault, you're also being charged with battery. Assault is the threat, while battery is the actual physical striking of another human. So if you are, somehow threatening a patient, like I'm gonna, go get in the ambulance or I'm gonna, restrain you, that could be perceived as assault. Actually hitting a patient or groping. I know there was some issue a bunch of years ago where intoxicated female accused an FDNY EMT, I believe it's FDNY EMT, of licking her nipple. That would be considered battery because that is without her consent. We also have to be concerned about consent, right? If you were going to start an IV on a patient and you have not acquired their consent to do so, that could be considered battery, okay? And we'll talk about different types of consent or review different types of consent in a few. False imprisonment. We have decided to restrict a patient without proper justification or consent, right? So you have somebody who's screaming, crying, carrying on, but is ANO 3, and they're, screaming, crying, and carrying on because they have just lost a family member, and you restrain them chemically or physically to bring them to the hospital. That is false imprisonment. It also could potentially fall under kidnapping, whereas you seize someone and then move them away from a scene by force. So you have to just be careful. This is why consent is so important.
Well, at that point, in that case, too, especially with the city, that falls a lot on PD. Well, at that point, in that case, too, especially with the city, that falls a lot on PD. If they're making that determination to do it, then it's documented as per NYPD.
And that falls under their mental hygiene laws. You, as an EMS provider, cannot restrain someone to bring them to the hospital without PD authorization. Even medical control can't really provide you with that legal right to do it. The mental hygiene law is very precise in that. So this is also why if you're picking up a patient from the facility, they need a 2PC form, right? So you have two physicians signing off that this patient requires transport, even if it is in fact involuntary. Other legal issues that you may have run into in your career, defamation, right, where you're making a either written or verbal statement that is injuring a person's good name and or a reputation. And these can fall on the defamation can be libel or slander. With libel, and this actually one of my guys just told me that this showed up, libel and slander showed up on the National Registry exam. So just remember that libel is written and slander is verbal. Slander is speech, okay, SS. So that's if you want to try to keep those two. Libel is written in a letter, slander is speech. Both are false statements. Medical Practice Act basically sets the bullet points for what the minimum qualifications are for each person working in various health services. So they're the ones who tell you what a respiratory therapist can do, what a CNA can do, what an EMS provider can do, right? At different levels of licensure and or certification. Their scope of practice is like each state outlines. So while in New York State, a paramedic could intubate, in Montana, a BLS provider might be able to intubate. Okay, so it depends on each state who to define what each certification level can do what. Here's another concern that we saw in Jersey City Medical Center. Paramedics they arrived on scene for a mother who was in traumatic arrest. She was full term, and they called medical control to determine if they could do something to help save the baby. It was a traumatic arrest. The mother was involved in an MVA. They were doing resuscitation, and the medical control physician walked them through performing a perimortem C-section. So they delivered the baby by surgery, which we are not really generally allowed to perform surgery in the paramedic level. The baby did survive for a week before ultimately passing away. Both paramedics lost their licenses. So, if the baby had lived, do you think they would have lost their licenses?
No.
Why?
Yes, either way.
No.
But why?
I think it's ridiculous that they did.
Yes, either way.
It's out of their scope of practice.
I think it's ridiculous that they
It's
did
out of
this.
their scope of practice.
It is, but they're being. It is, but they're being told to do so by medical control.
It doesn't matter. You know your you know your protocols. The doctor could order you, but if it's out of your scope of practice and you fail to notify him and say that's out of my scope of practice, I can't do it, you're in violation of the protocol.
Exactly.
What are
I
some of
think
the
they
other
should have just
alternatives?
refused and said that they can't do it because out of their protocols.
CPR and
That's like
doing CPR.
I mean,
I think you would have continued CPR and transported doing CPR, and I mean, I just think that would have been
doing what's in your scope, within your scope.
right. Well, and
It's true.
if you could keep blood circulating, you could potentially keep the baby viable.
I agree
But
with
you-
that. I think I'm all for doing a C-section in the field. However, I think that they should have done something the entire way, whether that's transport the patient, even though
So
it's
my
technically
question
dead,
with this too is
whatever,
they don't
like, I
really
would still
say where this was in relationship to the hospital. Was it extended transport time? Why were they on scene for, at least, I'm assuming at least 20 minutes if they were doing something, doing CPR, right? It's a traumatic arrest. Why are they not moving? Why are they still in one spot? Was it an extended extrication, etc.? So there's some considerations there that why were they still on scene calling rather than just transporting? Go ahead.
So is this the
Wait.
case that ALS
I have a
kills
question.
the trauma patient? So is this
Didn't-
the ALS case
Partially.
that ALS
This is one
kills the
example.
trauma
Who had a
patients?
question?
I had a question, Christopher.
Hi, Christopher.
Did anything happen? I had a question, Christopher. Did anything happen to the doctor?
So this
Or,
actually,
like,
this also kind of is one of those quote unquote shit trickles downward kind of thing, right? So they were acting in good faith based on the information, the direction that the doctor provided them. Yes, they should not have done it. They should have said, that's not in my scope of practice. You know what? Let's just transport. However, the doctor, they're operating under this physician's license. So ultimately, they both got their licenses back as paramedics because they were acting in good faith. They were trying to do what was best for the baby. And the physician was supposed to have been also aware of the scope, the EMS's scope of practice, and where they were able, like what they were able to provide in terms of care. But again, I still want to know why they were on scene for so long. And that documentation must have been phenomenal for them to have gotten their licenses back.
How are they able to give a C-section if we don't carry scalpels?
OB kit.
How are they able to give a C-section if we don't carry scalpels?
In the OB kits we used to.
Yeah.
Oh, okay.
No, some places still have them in OB kits.
EMTALA! You need to know EMTALA. It pops up everywhere. Every patient has a right to transport to an appropriate facility, at which point they will receive, at the very least, a physical workup and a management of life threats, regardless of their ability to pay. This was happening a lot in, I think, the 80s, early 90s, which is what even caused EMTALA to be an issue.
Insurance, get out.
Exactly. Hospitals were like, don't bring them here. They don't have insurance. And they're like, yeah, you can't do that. You have to treat them. You're a hospital. It was also patient steering became an issue where you would see patients who had good insurance being brought back to the home base and patients with not so good insurance being brought to a different hospital. This is also designed to protect pregnant women in labor. That you have to, at the very least, manage the patient for any life threats. You might even have to deliver that baby at that hospital before you bring them to an L&D hospital if they were not transported to an appropriate facility, right? So imminent birth, you're going to get her to the hospital kind of thing. Instead of going to the L&D delivery area, they still have to take care of her. They can't just kick her to the curb. So, transportation, and this is one of those things that is kind of challenging and was definitely canceled during COVID. So, patients should be transported to the facility of their choice when possible, reasonable, and appropriate. Yes and no. So, the problem with out-of-area hospital transports is it tends to put undue stress on the system, right? So, just because I know this general thing really well. So, right, you have Jamaica, Ozone Park, Howard Beach. This is the where Jamaica Hospital tends to kind of cover, right? We have 2 ALS units, 5-1 Willie, 5-1 Victor. They also get pulled down into the Rockaways, okay? So, like, this is being covered by 2 Jamaica trucks and, like, 3 FDNY trucks. So now, there was one lady who always, about 8 o'clock at night, wanted to go to Winthrop. And she would always call having chest pain. She wasn't having chest pain. So we pick her up, and I have to go to Winthrop. So now that's, 40 minutes, because it was always rush hour, 40 minutes to an hour to get to NYU Winthrop. Half hour to triage. And then 40 minutes or so to get back. So during that time, that's one unit, the one ALS unit that's out of service. So now you're pulling in units from the Glendale area. You're pulling in units from, all around here to cover here, which leaves this area less protected. So yes, it's nice to be able to bring patients to the hospitals that they want to go to, but there's also patients who live down here in Howard Beach and are saying, I need to go to LIJ, which is, over here somewhere. It's rush hour. They're bleeding from the face with, facial trauma. The closest trauma center is Jamaica, and they want to go past a perfectly good trauma center to another trauma center because they get a personal TV. So sometimes you have to also tell the patient, no, it's not possible, it's not practical, it's not reasonable, and it's inappropriate for me to go past 2 or 3 trauma centers just because, you saw a doctor there once about your overgrown toenails. Take that into consideration.
Aren't there loopholes in place so you can do these things?
So in the city, it's the 10-minute rule.
Aren't there loopholes in place so you can do these things?
For example, a patient's like, I don't feel good, I need to go to the hospital, and they want to go to, over here, they want to go to Forest Hills. You're in Ozone Park, Jamaica's 10 minutes away, Forest Hills is 15. As long as it's no more than 10 minutes past the nearest appropriate facility, then they can go. They can't.
Isn't there like a reassessing? Because like after 10
Isn't there like a reassessing? Because like after 10 minutes, like you can reassess and like, okay, wait, we can actually make it.
After that telemetry,
They'll
you
be
have to
okay.
call and get permission to go.
That's telemetry
but for the most
approval after
part,
that.
yeah.
The first thing they ask you is why does the patient want to go there? Have they been there before? And 9 times out of 10, the first thing they ask you is why does the patient want to go there? Have they been there before? And what is your ETA to that hospital? And how many hospitals are you passing?
We had that exact issue yesterday where we were in Jamaica and the patient wanted to go to Forest Hills, and it would have been about 25, 30 minutes to there.
And were they granted permission?
They called telemetry.
Yeah, so for the most part, they don't say no.
We did it yesterday from Jamaica we did it yesterday from Jamaica to Tish.
Patient before me. So keep in mind, I watched we had a patient before me at triage at St. Francis who came from the Rockaways and was critical, completely unstable with a BLS truck. And the two technicians on the ambulance were furious because their dispatcher made them honor this patient's wishes and go to St. Francis. But the hospital lodged a complaint. Well, and these poor guys could lose their. Well, I know. I felt very bad. Their cards. They knew they were doing the wrong thing. But I mean, it's very difficult. Well, I know. I felt very badly for them because they knew they were doing the wrong thing. They did not contact medical control. They only contacted their company's dispatch. They did not contact medical control. They only contacted their company's dispatch.
They were private.
It wasn't a transport unit, but the family knew well enough to call a private ambulance service for this patient. And man, it was just the doctors and nurses at St. Francis were furious. They were calling the state like it was a bad situation. So I'm only putting that out there to tell people just be careful because you're in charge of that patient.
So here's the thing about the privates is that if they request, you are supposed to do it, right? Obviously, you want to give people what they want. However, if you can recognize, obviously,
hey, this patient's unstable, we need to divert.
They shouldn't go there. You should go, oh, well, the company is saying, well, we have to do this. But some people don't know that, and they just go, oh, well, the company is saying, well, we have to do this. Some people don't recognize the difference.
And when I say bad, this was a BLS team. The patient was tacky at 220 with a SAT of 62.
And that's like an hour and a half. That's easy, an hour and a half.
And they came from the Rockaways, Washington.
I think it's like a communication thing with the patient and the family. I think that's like a communication thing with the patient and the family. Like I've had people same idea, and I'll turn around and be like, "Hey, listen, we're not going to be able to get to that hospital right now. However, what we could do is we could take them to the closest hospital, and then if you really like that hospital, sometimes they'll transfer them out as soon as they're stable. You could work on that, but this guy's to the hospital now."
It could also be an issue with the company if they're punishing employees who are technically doing the right thing, but against the patient's wishes, kind of like that. Where if the patient wants to go to one hospital and they divert to another for
you can't punish somebody for
medical
that.
reasons, and then they
die.
get punished
I'm not
for
going to trek around the countryside for that. That sounds like inexperience.
Can punish take away shifts kind of thing.
Oh, and that's retaliation. And
companies can punish
really nice
take away shifts kind of thing.
So what's funny is that
legal.
So what's funny is that so if I'm ever working out east, like on the island, since Northwell pretty much owns everything, people are like, oh, well, I want to go to Mather. We're not going to Mather. We're going to Peconic Bay because you'll transfer out and you're in the same system. And a lot of people forget that. Oh, well, my doctor's at this place.
Yeah, and it's not like your doctor's going to meet you in the ER. Like
being contacted.
You're not going to see your doctor. People also don't realize how portable most health information. Yeah, you're not going to see your doctor first of all, and people don't realize how portable most health information is now. Like just throwing out, for example, I got my COVID vaccine at a Northwell facility, and my primary care doctor is a Catholic health system doctor. And as soon as she opened my medical records, that information was there. So the information, people need to know that information is portable. Like you don't have to go to the hospital system that your primary care doctor is at to have your medical information transfer.
Yeah, even still, like if you go to like Catholic Health versus
it's not hard.
Like they can give the information
with electronic health records.
And if not, they're going to ask you a million questions anyway in triage. So
with electronic health records, it's just very easy to transmit that information.
The scenario where they and I have to say one thing is with the scenario where they ask dispatch, what they should do. At as a dispatcher at a somewhat okay agency that I'm at, my response is, contact medical control. That's not my problem. That's not my call. And then, it depends how it's documented, but then that can fall on a dispatcher, that can fall on a supervisor, that can fall on everybody else.
That's why in the city, when you call medical control for an extended transport onto a different hospital, you're painting that picture for the doc, especially since it's on a recorded line. If you half-ass your version of it and they approve it and something happens to that patient, you're on the hook. They're going to pull that record.
Well, I mean, the patient. It's also your responsibility to. It's also your responsibility to constantly monitor your patient, because they tell you when you're going out of or out of area, if anything happens, you need to divert to the closest hospital at that point. Part of the other issue is that in the 90s they shut down a lot of hospitals. So now you have a reduced number of available hospitals to go to. So if you're in the Rockaways, you're, or you're kind of in this like weird in-between zone, like in like this part of Jamaica, you can go to Jamaica, or you can go to, then you have like Franklin is like your next closest from there, or you can go St. John's Episcopal, which I wouldn't take anybody to by choice. So like there's a limited amount. Like even what I was saying the other day, like I had a pediatric trauma down in Rockaway Beach, right? We went up to Cohen's. It was a 40-minute transport. They were saying, oh, you should go to Staten Island. I was like, that's also not that close. So, you have to look at the resources that are available, and a lot of those have been kind of eliminated to try to reduce competition, or I don't know. They were like, oh, there's too many services. I don't really see that ever being an issue.
That's like going to them Tala. Like before, there's one particular hospital, they'll discharge a patient and throw them out after they have seen them, and they put them in the waiting room, and then they call 911. We show up, and it's a PD matter only, because we don't transport from hospital to ground. And they get all annoyed at it. No, so what they started doing now is they tell the patient to walk 3 to 4 blocks up the road and then call 911.
So I was working Lakeland probably like last year, like when COVID was like in the hype, and there was a kid who had fell down the stairs, and he was like 13 or 14, and the family was like, oh, he has to go to LIJ. And I was like, listen, we cannot transport him to LIJ. We could go to Stony Brook, we can go Brookhaven, we could go pretty much anywhere that's not 45 plus minutes away, because even if with all these other issues, that there's no way. And they RMA'd him, medical control approved it,
well,
and they
you did
drove
what you
him
had
to
to do. Like
LIJ,
you explain the risks to patients, and they don't. Sometimes people don't get it. Mandated reporting, we talked about this already a little bit, so I would, if you want to put this number in your phone if you don't have it already, you're a mandated reporter for child abuse. The form is here. It has to be done within 24 hours. You are not required to report adult or elder abuse by law, but it is advised that you do so. Personally, I have had zero luck actually getting through to the Adult Protective Services people. I know, Vinny, you said that you had an APS the other day.
And their response was, why you notify? I got through on
there's
once
not a lot of
and their response was,
most
why
of the
you
time,
notifying us?
Ensuring that social work is involved during triage, and you say they need social work, is usually more successful in terms of actually helping that person. Consent, super important. You need to have these down cold. You should have them down cold already, secondary to the fact that you're already EMTs. So informed consent, right? You have to obtain this from every adult patient who has decision-making capacity, right? So this patient is awake, alert, oriented, understands what's going on with their health, and can make a decision based on it. This means like the patient, you're telling them, hey, you're having a massive heart attack. They're like, no, I'm not. It's fine. That patient, that I would call medical control for that patient, because they do not seem to understand the gravity of their situation. But you need to explain to the patient what's going on, what you believe that their issue is. what you want to do in terms of your treatment for them. This is like, hey, I need to start an IV so we can give you some fluids, or we might have to give you medication while we're in transport. Can I start an IV? Yeah, sure, no problem, right? But you also need to explain the potential risks. So like, if I don't do it, I might not be able to get you medication in time if you start to have like a bad heart rhythm. You can discuss alternative treatments. So if the patient's needs, a medication that can alternatively be given IN or IM, that's a possibility. They say, oh no, I don't want an IV, but you can stab me with a needle. That's okay. Do that. And then consequences of refusing treatment. So, and this is really important, and we're going to talk about this in documentation, right? But you need to make sure that you've explained everything to the patient and what potentially could happen if they refuse, up to and including death, right? Because once you put up to and including death, that's a really great umbrella statement of like, you could die. We explained to you that you could die and you still didn't want to do this. Expressed is a verbal or nonverbal permission, right? So if you have a patient who is unable to speak, they might nod. They might give you some sort of indication that they would like you to take care of them. And then you have implied, right? This is all your unconscious patients. We use implied consent because you would assume that if they were awake ANO times 3, that they would want you to save their life. Implied consent also, in some cases, is for kids without parents, right? So if the patient or the parent was aware of the child's condition, that the parent would also want you to do everything in your power to save that child, okay? Because depending on the child's age, right, the younger kids do not have the ability to consent by law.
What is the specific word for that? What is the specific word for that?
Children
when
can't clear capacity assessment, right?
But like
Children can't clear capacity assessment, right?
No, not even that. There's a specific word for when a child is under the care of emergency management.
Yeah.
In parentis locus. Same with the school. The schools can give consent because schools automatically have. So, in case you're all not aware, but I'm on a school board, so I will tell you, if you transport from a school and there's no parent, you should take a
then that school official is able to make certain decisions. It's in parentis locus, is like in lieu of a parent or in standing of a parent. So when you as a parent, when you send your kids to school, you are allowing those adults to act as a parent for the child for that 8-hour period. So most of the time, those school officials are hopefully trying to reach out to the parent, but you do need to make sure that you have an adult with you, if available. If not available, you're bringing a cop with you. Okay. Also, make sure that you, depending on where you're working, understand what the age of consent is. In New York State, it is 18. Other states, it is younger. So just be aware of that.
And if it's a public school or any good school, but I will tell you, we had a parent who. And if it's a public school or any good school, but I will tell you, we had a parent who tried to revoke in parentis locus and tell us we were not allowed to call an ambulance for their child. I'm talking about on the school district side now, not on the EMS side, and wrote a whole letter to our school district and our school district attorneys revoking the right for the school district to call an ambulance without express consent of the parent. And it was the first time our attorneys have ever told us we can tell that parent they cannot send their child to school without this.
I would also be like, that's a CPS report right there. Like, you don't want your kid to be safe?
Well, because, we transported, to make a long story short, the child fell off the monkey bars. We transported the child, or the school called an ambulance. Our ambulance company transported the child. I happened to be on the call and on the school board, so it was a little weird. But I took the child to the hospital. The child had 4 broken bones, and the parent had wanted the opportunity to, including one in a disc in the spine. And the parent thought that the child should have come home so they could try inversion therapy before we took the child to the hospital. Yeah. So they didn't want us to do that again if the child fell.
Thank God. What a moron.
So yes, CPS got involved in that too.
At the same time, with that protocol in itself, a school itself is the only one, if the child is stable and it's based on EMS personnel.
Yes, but it also needs to go through medical control also for extra liability. Yeah.
And I would tell you 10 out of 10 as a school district
telemetry.
representative, we're
Yeah.
sending the kid
So
in
if
the
you have a
ambulance.
school,
And I would tell you 10 out of 10 as a school
Yeah.
district representative, we're sending the kid in the ambulance. We're doing the same thing that you're doing as an EMS provider, right? Your
And
best
I've had schools
Yeah, I mean
accept the
but that's
RMA
also
because
having
parents they don't
communication
want
with
their
the
kids to go to
parents, so
school as
it's
long as
not
the kid
true
was stable.
parentis locus.
Right, the school's not making that decision, then the parents on the phone. Well, that's right, that's not the school. Right, the school's not making that decision, then the parents on the phone making that decision, that's completely different, but if, yeah, no way, no way. If one of my nurses or one of my school officials RMA'd somebody that they thought enough they had to call an ambulance for, I don't think I'd want to continue to employ that individual.
There was a question on my state exam 5 years ago about how when there's a school bus accident and there's all these kids on the bus, do you have to RMA all of them, or can you just technically do one? And I'm pretty sure the answer from that, like 5 years ago, was that you can just have a school administrator RMA all of them as one patient. And I know
every
it
single
weird,
child needs their own RMA. The school official can sign in parentis locus for each one of those children, but you need documentation for each child.
Nicole?
Yes.
Last week we had a very kind of messy call. Nicole? Last week we had a very kind of messy call. It was a parent who called for his son who cut his hand on a car door, and then the parent left.
PD.
And we couldn't transport him because there was no other adult on scene. We called for PD, but they hadn't arrived yet. And while we were waiting, some other guy came and claimed he was the father and took the child. He claimed he was the father, but we knew it wasn't him because the father was in Brooklyn picking up the grandmother. Turned out it was the uncle, but he claimed he was the father for whatever reason. They went back inside the house, police arrived, and apparently the child ran out from the back door and we couldn't find him.
And that's one of those really like child physically removed from EMS, care by purported. That's just messy.
But if he just told us he was the uncle, he could have RMA'd him and taken him. But if he just told us he was the uncle, he could have RMA'd him and taken him himself.
I can't.
People
are a little out of control these days. It's wild.
Isn't an uncle not a legal guardian though?
Huh?
Isn't an uncle
not a legal guardian though? Isn't an uncle not a legal guardian though?
Yeah, so like if the father was on the phone saying, yeah, you can release it to this child, so that wouldn't have been an issue, but
we spoke to the father on the phone about it. Yeah, fine, but like the uncle claimed he was. We spoke to the father on the phone about it, and he said that's fine. But like
right
the
there that I
uncle
don't want
claimed
to
he
have
was
to
the
answer.
father while we were talking to the father.
Yeah, it doesn't even matter in the grand scheme.
Isn't that gray area
with the kid ran out when it involves a phone call because literally you don't know who you're calling because it's not a face-to-face.
Isn't that gray area when it involves a phone call
because
literally you don't know who you're calling because it's not a face-to-face
in terms of
interaction?
trying to get someone medical care, like you can kind of be like, PD spoke to the person on the phone and authorized care or something like that. Especially if you're still going to be ultimately transporting with PD, that's not as much of an issue, especially for a minor. But all right, so decision-making capacity. This is also one of those things that is not really well defined in the law about what needs to kind of be qualified. And this is also one of those gray areas. But generally, we try to determine that a patient is ANO 3 or 4, depending on and that they understand what's going on. They have the autonomy to make decisions regarding their own care. So if they don't want pain medicine, even though there's a bone sticking out of their leg, they have every right to do that as long as they're ANO 4 and understand the consequences. The other issue is end of life care, right? So we have DNR DNIs. We have there's other states that actually allow for doctor assisted end of life. So there's a lot of different aspects there. So decision-making capacity, here's some other aspects, right? So you want to make sure that there's no mental impairment secondary to a number of different issues, including but not limited to alcohol, drugs, head injury, organic illness such as mental illness or dementia. They understand the risks of not seeking immediate care. So, you tell them, hey, you could die. And they're like, no, that's all right. I understand if it's my time, it's my time. Little Zen kind of vibe. That could be one thing. They have some sort of reasonable plan, right? I am going to go to my doctor tomorrow. Okay. make an appointment. Okay, I have an appointment later today. I was gonna go because I wasn't feeling well, and right now I'm not feeling great. SpO2 and blood glucose should be within normal limits. Normal limits are also kind of for BGL and or SpO2 can be extremely patient dependent. So if you have a bad COPD individual, they might live at 92 regularly, and that's okay, right? That's good for them. Diabetics, right? They might be a little higher than type 2 diabetics in particular. They might live at a little higher range than your other normal people. And there should be no distracting injuries, right? Because that usually will complicate decision-making capacity. But that doesn't mean that they can't then dictate their care in terms of what they receive. If they don't want you to give them pain medicine, you don't give them pain medicine, okay? I think we pretty much talked about this pretty in loco parentis. There we go. Covered that already. Check. Minors cannot refuse nor consent unless they are emancipated, and those kids will have a legal document saying that they are emancipated, that they live on their own, free from their parents. In New York State is anyone under 21, but I do believe we kind of honor the 18-year-old range here, unless they are married, in the military, have already completed 4 years of college, has permanently left home and or ended the relationship with their parents, and or were working full-time somewhere. You need to
just have a quick question about that last one.
Go ahead.
I know just have a quick question about that last one. I know it's like a very, very specific example, but what if it's like a child prodigy who's completed 4 years of college at 16?
Emancipated. Ask them to show the degree. Yeah, like you could have a child prodigy at that point. I would potentially consider them, especially if they're not living at home and they have completed college, I would potentially consider them, emancipated. Yeah, pregnant. I just saw a question about pregnant minors. They are considered emancipated whilst pregnant, and then afterwards they are no longer emancipated, but they can make decisions for their children.
And I'm pretty sure you're right, Nicole. It is 18 because my kid's doctors won't even talk to me now that. And I'm pretty sure you're right, Nicole. It is 18 because my kid's doctors won't even talk to me now that they're 18. So I don't know why it says
law. New York's emancipation law. I don't know why New York. This is the New York State law. I guess that there's some special considerations. They also might have changed it because of that when they changed the healthcare laws to kind of cover kids up to 26 with parental health insurance. I think that is why they changed the emancipation.
Yeah, it's very strange because my kid's doctors won't talk to me, but I still get the.
They still get the bill.
Yeah, it's very strange because my kid's doctors won't talk to me, but I still get the. I still get the.
Yeah,
I still get the statements from the insurance company and the bills and all that kind of stuff. So.
Going back to the minors can't refuse or consent. Going back to the minors can't refuse or consent. If you do have the parents' permission and everything, are they allowed to refuse a specific treatment? Like, I don't want that IV or something along those lines.
That's again, that's going to be dependent upon like the child's status. Like, you're not going to necessarily just go, even if parents like treat my child, and it's like, no, like I'm really afraid of needles. Please don't. Maybe you can work around that. Like, I think that that's just being a nice human, not necessarily, you know what I mean? If you have to explain to the kid, like, listen, like, you're really sick, I really need to start this IV, I'm so sorry, like, we're gonna do everything in our power to not make it hurt that much, like, that's gonna be, like, your interpersonal skills and trying to make sure that, the kid's getting the care that they need.
But now, is it considered battery if you do a treatment that they don't want? If it's a child that's minor? But now, is it considered battery if you do a treatment that they don't want?
Probably technically no, if the parents give you permission.
With that issue?
Again, it's one of those gray areas. And most of the time, I don't think you're really going to, I'm hoping that a lot of you won't ever have to deal with that situation. Again, that's using your interpersonal skills and maybe explaining to the parent, like, listen, like, can you talk to your child? Let's, we're going to try to do something this way instead of this way. Or getting on the phone with telemetry and saying, like, hey, I have a child. The child is absolutely refusing to let me start an IV. I really don't want to agitate this kid anymore. Can we do something else? Or, hey, can I get maybe a little Versed to calm them down? You can do that, IN without causing any issues. So you also have to kind of be a little creative and work on your feet.
I have a needle phobic child, and I will tell you even in the emergency department. I have a needle phobic child, and I will tell you even in the emergency department when they're trying to start, and she happened to have a brain tumor, so some major medical issues. And you know, it got to the point where I actually have a prescription for Valium. I would give it to her, you know, if she needed medical care, just to calm her down enough that they could get an IV in her.
They needed to hold me down yesterday to give me an IV.
Wow, so there's no one to practice for you when we got to do IVs, but isn't there like you don't even have to start an IV unless it's absolutely necessary though. So you can just leave it for the hospital. You don't have to give yourself the headache unless you
now you get to
really
that
need
age
it.
range where they're like maybe a little prepubescent and you might have to start an IV because maybe you have to give them Benadryl or you have to give them something for like an allergic reaction, right? Yes, you're going to potentially start an IV for that kid because they're in that prepubescent range where they're in adult protocols but not making adult decisions. So you might have that little bit of overlap there that's going to make it complicated.
I also used an IV as like a specific example, but I mean it could be like anything. I also used an IV as like a specific example, but I mean it could be like anything. Like what happens if it's oxygen
or they're just
and
super
they're an
hypoxic.
asthmatic and refusing albuterol because they're being stubborn for whatever reason. Like
No.
13.
I was gonna say you can't like lose your license for that for like administering a treatment that a patient doesn't want.
Well, that's
and
also
then
when it comes to documentation.
Like that's,
you know, apply the nebulizer.
Concerning.
Patient ripped it off their face. You know, explain to the patient that they need the medication. A patient could not, you know, was unable to consent. Contacted medical control for suggestions or for consults. Nothing helpful. So it's about also covering your own butt.
Make sure your documentation matches what you're saying on that recorded line. That's where. Make sure your documentation 100%. Matches what you're saying on that recorded line. That's where you can
also
cover
now
yourself.
Since we kind of had a nice segue into that, your different levels of negligence, right? So you have malfeasance, is when you do an act you are not authorized to do. This is that perimortem C-section, right? This is where they got jammed up. Malfeasance, it's outside of their scope of practice. Misfeasance is you have the authorization to do it, but you do it wrong or inappropriately. So you go to intubate somebody and you put it in the stomach and you don't correct the issue. That's misfeasance, okay? And then nonfeasance is you have something that you're supposed to do and you don't. This is your patient's in cardiac arrest, you fail to recognize it and you fail to perform CPR. Okay, so those are your three in terms of how you can get jammed up with negligence. I guess the saving grace of negligence for us on the provider side is that a lawyer needs to now provide those four different things: that you had a duty to act. So the second you step on the ambulance as a EMS provider, you have confirmed duty. You have breached that duty. Okay, so you were dispatched to a call and you decided not to go. Breach of duty. Because you didn't go to that call, there's some sort of proximate cause, right? You are the cause that patient went to respiratory arrest because of an asthma attack, because you didn't go, you didn't show up, and then that patient suffered harm. So because that patient went into status asthmaticus, they became hypoxic and they suffered an anoxic brain injury. All of those need to be established in a court of law for negligence to be a viable charge. One form is also abandonment, right? So this is that you have terminated care without the patient's consent or without handing this patient off. So you go and bring a patient to the hospital, you bring them into triage, and you don't get a nurse's signature, you just dump them in triage and take off because it's the end of your tour. That is abandonment, okay? This is why making sure getting a signature from the triage nurse is essential. I am not, because I wasn't aware of that, medics. Yep, if you can't hear, log out, log back in. Advanced directives, okay? So we have a number of different advanced directives that patients have legally. We can only recognize the DNR, DNI / out of hospital DNR, DNI, and most patients who are out of hospital now are being given the most. Okay, nursing homes will have the out of hospital DNR, DNI. even if the signature is expired, you are able to acknowledge the DNR DNI. Please, 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 make sure you read the MOLST. I had a patient once, she had a terminal brain tumor. Family's like, we have a MOLST, because she had stopped breathing and lost pulses about 20 minutes prior to them activating 911. They hand me the MOLST, and on top of the MOLST in the doctor's handwriting was a big old asterisk that says, patient is alert and aware of what she is doing. She wants all life-saving treatments rendered. And every single box that was checked off was do CPR, give me antibiotics, intubate me, do all of these things. And I was like, anybody read this? None of y'all read this, did you? Okay, so just make sure that you read the MOLST. The MOLST is very specific in what you can do for a patient, including CPR, intubation, IV fluids, in the hospital, antibiotics. Okay, so it really outlines what the patient wants done. We cannot recognize a living will or a healthcare power of attorney. However, that does not preclude you from, when calling telemetry, saying the patient's family has given me a living will. The patient's in the living will, it says the patient does not want resuscitative measures. Can we honor the living will? Most of the time, the doctor's going to be like, yep, that's fine, cool, I acknowledge it, time of death. Or if you have a healthcare power of attorney who is on scene and says, I'm a power of attorney, I don't want CPR performed, I don't want this, that, the other, you can call telemetry and say, I have a family member here who is a power of attorney, they'd like to speak to you. And let them hash it out on their own, because then that's perfectly legal. I talked about this very briefly before. There are some states that have a dignity to die set up. Oregon, I believe, Oregon or Washington was one of the first states to do this. I don't have a slide on it. So basically, if you have been diagnosed with a terminal issue, you see 2 different psychologists who sign off that you're in a right state of mind, and then you are prescribed a cocktail of medications that will allow you to die peacefully. And when you have decided it's your time, you are able to die with dignity, rather than, potentially going through long medical procedures, being admitted to the hospital, your family watching you wither away into nothingness. I'm a huge proponent of the Dignity to Die Act. I think that they put in a lot of kind of stop, some safeties for people, so like you're not just making a knee-jerk reaction that, oh well, I have a brain tumor, I want to just pass peacefully. It is a terminal. There is a terminal diagnosis. You are seeing mental health people to make sure that you're making this decision in a good state of mind, et cetera, et cetera.
That also goes to just the opposite with the DNR. A patient has a DNR. That also goes to just the opposite with the DNR. A patient has a DNR, a MOLST, but the family now wants you to resuscitate.
If the family's insisting that you resuscitate, bring them to the hospital and let the hospital, get out of that situation, right? If that's the family's like, no, we don't honor the DNR, don't honor it, like we want you to do everything. Okay, sure, no problem. Do CPR, get him into the ambulance, do everything that you're supposed to do, get to the hospital, hand it off and say, patient has a DNR, DNI, family didn't want it to be recognized, here you go. A lot of times people kind of panic and that, are kind of in that denial stage of grieving. So you're out of the situation, you're safe, you've done everything that you're supposed to do in that situation. The hospital is just going to pronounce, and then they can deal with the family there. They've got social workers, they've got, emotional health people, all that stuff. Let them deal with it.
But if you get Brosk back and the person actually comes back, can't they sue because you didn't? But if you get Brosk back and the person actually comes back, can't they sue because you didn't honor the DNR?
Do it. I mean, yes, but in the court of law, they're not gonna. I don't really think that's going to stand up. You're going to say the family refused to give it to me. You can't acknowledge it until it's given to you, honestly. So if you never received the DNR, it's not real.
I would say 9 times out of 10 if they're asking, they're not going to give you the DNR. I would say 9 times out of 10 if they're asking, they're not going to give you the DNR. You're not going to get the MOLST form. I've had that happen a couple of times, and we get to the hospital, and the hospital has the forms on record, but we didn't have it. And I mean, it happens all the time when we get there and you can't find anything in the house, and so no one's there, and you go through and I've gotten yelled at a couple of times by emergency room doctors.
Not that it was provided to me.
I'm like, well, again, you know what? Not that I saw.
Yeah. You can't acknowledge it unless it's in
They
your hand.
weren't in their home,
Because
whatever.
Arrest in the morning.
Mhm.
We worked that actually happened to me yesterday. We had a cardiac arrest in the morning. We worked her. We actually got Rosk back. So we got downstairs probably 15 minutes after we started CPR, and only once we got downstairs
I've had that also. I had a
the
patient
family
who
member say they
had
had a
an
DNR.
inoperable brain tumor, was on all sorts of stuff, seizing. We got him to the hospital. He was still seizing, even though we've jumped our entire drug bag into him. The hospital intubated him. The wife showed up. It's like, he's a DNI. Okay, like. We were on scene with you for like 20 minutes. You didn't give us anything. We couldn't tell the hospital this. Now it's too late. He's already intubated. So let the hospital deal with it. Do everything in good faith on your side. And again, if they give you the DNR, you can acknowledge it. If they don't hand it to you or they rip it up in front of you, which I've also had, it's not real, right? It's not real unless you can get your hands on it.
I mean, look, I've had people rip it up literally right in front of my face and say, "No, you're doing it." I mean, look, I've had people rip it up literally right in front of my face and say, "No, you're doing it." I said, "No."
It's true. It's true.
I can't say that I have the document anymore. You know.
About that, though. You have to have the actual real.
There's stipulations about that, though. You have to have the actual real DNR documentation versus a copy of it, and it can't.
Form itself that it's not valid unless it's the original.
Nope.
I thought it says it right on the form itself that it's not valid unless it's the original.
Recently.
We've had families have it emailed from their doctor to their phone. We've had families have it emailed from their doctor to their phone.
Yeah, they've changed it. A lot of the electronic. They have the e-molsts now also, so there's no actual necessarily like a physical copy, or they email it from the patient's chart, right? They signed it, the hospital scans it in, and they email it to the family for reference for the future. So it might be a copy, but yes. And even if the doctor's signature is expired, you can still recognize the most or the DNR. Even though it says like, oh, it must be renewed every 30 days, like that people don't do that. Like, and that's okay. We can still accept it.
I don't know if anybody else works transport here, but like when you I don't know if anybody else works transport here, but like sometimes people do like hospice transfers, and for that alone, like they'll just give you copies because it's too annoying to give this person the original and this person that, like, so a lot of the times
as long as you have the actual physical paper with a signature, you're good. Because again, you're acting in good faith that this is the patient's wishes.
I've told I can accept, like I had a family member who had one at home and they were on the phone with the cops. I've also been told I can accept, like I had a family member who had one at home and they were on the phone with the cops and they texted us a picture
I
of
had
it,
a family who
which I can then attach to the PCR. So I'm
family
kind of
didn't
okay
have the
with
DNR
that.
on scene and refused to let us start CPR. So I got on the phone with telemetry right away. I was like, hey, I have a 98-year-old female. She's in cardiac arrest. Family says she stopped breathing over an hour ago. Family's refusing to let us start CPR. They have a DNR, but it's not on scene. Can I please get termination? And they're like, you're not doing CPR? I'm like, the family refuses to let us near the patient. They're like, well, how many of them are there? I'm like, I'm not going to fight them. I'm not doing this. Like, calm down, yo.
We had a job in Brooklyn where family said they had DNR, they couldn't provide it. A couple of months ago, we had a job in Brooklyn where family said they had DNR, they couldn't provide it. We started CPR. ALS intervenes, tubed her, everything else. Called for pronouncement 30 minutes later. Get the order to pronounce.
It's usually what happens.
As soon as we go disconnect the BVM and the leads.
Almost without failure, which is kind of funny. JK, we're going to transfer it.
Call telemetry back. Cancel out pronouncement.
The first lecture that we did with things that Nicole, this is back to your the first lecture that we did with things that you can do within your community. We actually have gone to our senior center and explained what we need for documentation for different cases and different, we've had it for family. If it's a dementia patient, what kind of information we need to accept you as the healthcare proxy and all that kind of stuff. So it's not a bad thing to do if you have senior centers, over 55 living environments or whatever, because people are, people have that piece of paper they fill out in the hospital that says they don't want to be resuscitated and they think it's good enough. They think we're not going to perform
a lot of people, like, the doctors don't necessarily explain to them that that's only good in the hospital. Like, you have to have like an out of hospital one, because I think a lot of doctors don't also understand that EMS has their own like laws for stuff, or guidelines that we need to have stuff as well.
I don't think the doctors always.
Yeah.
They don't really understand that.
No, it's complicated.
I don't think the doctors always. They don't
honestly,
really
if there was a little
understand
bit better communication throughout the healthcare system, it would probably be better off. But we'll get there one day. Good Samaritan law protects people who are responding while not on duty, and or the lay person. If you are a BLS provider or even an ALS provider, the Good Samaritan law doesn't really apply the same way, because you are now also required to act to your level of training. So if you roll up to a car accident and you're like, hey, like, whatever, you should, granted you have to have the equipment, like you can't to splint or do something like that, but like patients in cardiac arrest, you're expected to do CPR. Good Samaritan law, if they are not trained on CPR, they are not required to act. Even if they are trained in CPR, by law, they are a lay person is not necessarily required to act. Wow, I can't see that at all. Employment laws, so you have the Ryan White Act. I can't make that smaller. Americans with Disabilities, sexual harassment, all of the things that you've probably dealt with in terms of your annual trainings at any jobs that you may have. Ryan White Act, remember that one? That's if you have been exposed to somebody else's blood, etc., that is your person. That's usually a state question that pops up. All right, cool. That's that. We have one more lecture, but 5-minute break because I have to pee, so I'm sure somebody else also has to pee. All right, sound good? Back in 5. Oh, making me turn off my virtual background because my CPU usage is too high. Boo! I want to be on the beach again. All right, almost everybody's back. So let's wrap this day up. Lecture. Google. It's not the Chrome I want. There we go. All right, last lecture for today is communications. So we're just going to briefly talk about this, but you don't really need to know too much in depth, right? It's most of the time it's like, oh, I hit the button and then I wait a second and then I talk. Depending on where you are in the country, like if you have a mountain range or something, in order to make the radios work, repeaters are necessary. They're also pretty required in like the city, right? If you have tall buildings or stuff like that, you're going to need repeaters. A lot of this stuff has moved over to digital now, which has made the communications a lot clearer and able to go a little bit further. Portable radio, right? It's the one that you wear on your waist. A base station is sort of like where dispatch is. Repeater just takes the signal and then sends the signal further. And a mobile transceiver is your ambulance is considered a mobile transceiver. Different wavelengths, right? So we exist here in the radio spectrum, not in the optical spectrum, right? Hopefully you can't see radio. That's, if you can, you have some weird eyeballs. So we are over here, right? So the low frequency or very low frequency has a longer wavelength and can travel a longer distance. So like that's your AM radio stations. Whereas your higher frequency has a shorter wavelength and can travel a shorter distance, your FM radio stations. And we also, like, it falls, all of the are the radio bandwidths that we have for different agencies, etc., fall in here as well. this pops up on state questions pretty commonly. Simplex is one transmission at a time, right? So this is your regular old 5-1 Victor for the assignment. 5-1 Victor, right? Or you key up the radio and they're like, stop, you're stepping all over each other, because it's a simplex system, right? The dispatcher hits the button, they talk, they let go, you talk. One single person at a time, voice only. Duplex is sort of like if you were talking on a cell phone, right? You can have transmission and reception over 2 frequencies, right? So I could talk to you on a cell phone, you can interrupt me, vice versa. Multiplex is sort of where you have you can transmit other things as well. So this is where you're transmitting an EKG to medical control while talking to the dispatch on radio and maybe talking to the medical director on a duplex system. Okay, so you can have multiple transmissions going over 1 frequency at the same time. I don't know how trunking works. This is supposedly how trunking works. I'm not a huge radio nerd. There is always at least one huge radio nerd at every station who can hook you up with some sort of little radio, and we'll talk for hours about radios. All I need to know is when I hit the button, does my message go to where it needs to be? Moving on. Digital radios, what they do is they scan between the different frequencies, so for different channels, so that there's a clear one where you can talk freely. This is the trunked talk groups. This also has the ability to use CAD information, digital CAD information. So like now that like the health EMS system, a lot of people use health EMS in the city. It can actually incorporate your CAD and dispatch information and times from the CAD system right into your ACR if it's linked up. The digital systems have been very helpful in that. The Annie Alley, for anyone who works in the city and you've ever gotten a job and they're like, you're going to go here, and you're like, that's not a real place. You can look at the Annie Alley. The phone number is the Annie, and the alley is the automatic location identification. So basically it helps triangulate cell phone calls based on which cell phone towers are being pinged. Usually it's triangulated because you need 3 cell phone towers to send a thing accurately in terms of the GPS. Oh, cell phones have GPS receivers now because Big Brother's always watching. Biotelemetry, depending on what where you work and how you're sending things and what they want sent for your medical control, they will have different Rosettas or such. When I first started working in the city as a medic, this was like the Rosetta, and like there was a point where it's like if you couldn't transmit via the Rosetta, you'd change and you would send it over the radio, and it would send the EKG as like a dial-up more or less, and it didn't work great. The old school Rosettas didn't work great. The new ones are digital now and Bluetooth capable and all this other magic stuff, and they work much better to transmit stuff not only to medical control but to your health EMS and or whatever your documentation services are. Biotelemetry is kind of defined more as the ability to measure vitals and then transmit them elsewhere. You see this also a lot in the hospital, right? So maybe all your patients on the telemetry floor are on the monitor, and they have another screen with the monitor at another location, like another station where there's a EKG tech or somebody watching. It's all of the biotelemetry, because it is considered HIPAA or protected information, is encoded and then sent. Most of the time you're sending STEMI alerts, okay? I know in some areas, Suffolk, for example, they have BLS 12 leads where the BLS will send a 12 lead and let the doctor interpret it. So those are not necessarily STEMI alerts, but in the city it's STEMI alerts. On radio etiquette, right? The FCC is the department that monitors and polices the use of the radio frequencies. You are not allowed to cuss on the radio. Personal messages that every once in a while that fails to happen. People, open carriers are always like hilarious. If you do receive it, you should be receiving confirming that you have received it right at a good 10-4. I can't tell you the number of people who start talking before they hit the button, so you get half a message, or they have the radio mic like here, and you're like, please don't do that. Don't be that guy. Like, hold it out. Hi. Oh no. Puppy problems. And most of the time you need to identify who you are, right? So whatever unit you're working that day, you need to start your transmission with that. I can't tell you the number of times where I worked at the Willie truck and started off 5-1 Victor, and they're like, 5-1 Willie? Who am I today? What? Someone's getting very sassy. This is the information that you should be transmitting. Roger, shush. That you should be transmitting when you are providing medical information, such as a note or mostly a note, right? So you have your age and sex, your chief complaint, brief pertinent history of the present illness, relative medical history. So like if the patient is complaining of chest pain and they have had a toe amputated and nobody cares, what their level of consciousness and or distress is, mental status as well. This is important. A lot of people forget to include the mental status when they're providing a note, and they always ask, okay? Vital signs, they will 100% ask you to repeat vital signs every single time. They never ever get it. They never write it down fast enough. Any other pertinent physical findings, EKG findings, what you have done to treat the patient, and if they have responded to that treatment, and what your ETA to the hospital is. EMS timeout report, or the missed report. This is another way that you can structure your presentation. Okay. This is probably the one thing down here, the treatments, that's going to be a little bit different. It's going to start kind of getting a little more robust as we start learning more things, right? So did you tube the patient? What size tube? What was it at? What was the measurement at the lip line? What IVs did you put in? Where? What? How big? How much fluid? Especially septic patients, how much fluid was given in the pre-hospital environment is a huge thing. This is like one of the major QA/QI things that they ask about. So all these different things that you're going to include. Again, just another way to help you structure your presentation. Another way to structure communication, if you don't like the other one, but if this is also helpful down here, when you are potentially asking medical control for a medicine or a treatment, ways to clarify. You're saying like, hi, I want to do a synchronized cardioversion. Okay, you start at this joule setting. Okay, how often should I do it if it doesn't convert the rhythm, right? It just gives you some suggestions for questions that might be useful. I cannot tell you the number of times that people just don't introduce themselves and or find out what the patient's name is. It's one of my biggest things. I always forget to ask because I always get so focused in trying to make somebody feel better that I forget to ask them what their name is. Eye contact, sometimes good, sometimes bad. Some cultures do not appreciate eye contact, so just kind of be aware of that. But you should 100% make sure that you don't loom over your patient. You should be at the patient's level. That means if you have to bend a knee to look at the patient in the eye, that you need to do that. I had one partner once who always tried to speak very technical. Oh, yes, it looks like you're having a myocardial infarction, and we're going to need to bring you to the hospital to get a PCI performed. And the patient's like overwhelmed, right? Use plain language when you're speaking to a patient, okay? You don't have to prove that you're quote-unquote smarter or more educated than them. You need to make sure that they understand what's going on. You need to make sure that the patient is able to make a good decision for their own health based on the information that you're giving them. This is another thing, and we talked about this a little bit when we were talking about like the older dementia patients and the family jumps in. Give the patient time to answer. It gives you a lot of information about the patient as well. So if they're confused and you ask them a question and they're kind of taking their time, they're potentially trying, right? There may be something that you can fix. Maybe it's hypoxia or something. Maybe the patient has a little bit of dementia. Maybe the patient's translating, right? Maybe English isn't their first language and they're trying to choose the right words. Okay, so it gives you a lot of information. And always be calm, clear, cool, professional, confident. Even if you're not super confident, fake it till you make it, right? Be confident in your actions, and that will probably take you a long way. Little review on active listening, right? You should be paying attention to your patient. Make eye contact. Don't be like looking all over the place. Don't be buried in your ACR. Ask open-ended questions. Sometimes those give you information that you can't get with close-ended questions. Sometimes you have to do close-ended questions like, are you having chest pain? Yes or no, kind of thing. Open-ended questions is like, well, when did this start? And you have a conversation with the person. A lot of times people kind of don't succeed in healthcare because they don't have the ability to hold a conversation. And I kind of noticed it as people like start texting more and more, is that a lot of people have a harder time speaking to other people. Probing questions, right? So it's like, well, you said this. Well, when did that start? Or you kind of dig a little deeper, because sometimes you have to dig a little deeper into the patient's information to kind of get a good picture of what's going on. Request clarification for anything that doesn't really make sense. So the patient says that they were sleeping and they woke up and they had a broken arm. Like, what? Oh, did you do anything yesterday? Did you fall out of bed? You can also paraphrase what the patient says. So the patient's like, well, my doctor said to take this, so I did. Okay, so you went to the doctor yesterday, they gave you a new medication, and he told you to take 5 milligrams in the morning and 5 milligrams at night. Yes. Okay. Patients' feelings. Sometimes patients get a little agitated when you ask them questions. So just like, listen, like, I understand this is very frustrating. We just have to get a good understanding of what's going on with you so we can treat you the best. Okay? And then sometimes you have to also summarize what's going on, what the patient has told you, because sometimes things don't always mesh up, or sometimes you just need to have a little bit more information in order to do right by the patient. Hold on one sec. Hey, Mike, what's up? Not right now. I'll be there shortly. What's up? Okay, not a problem. Let me look at that in a little bit and I'll get back to you. All right, bye. All right, cool. A couple of different things that you might see in terms of how to effectively communicate. A lot of these are pretty straightforward. There's just kind of understand the definition of these things. I don't need to read them to you. You all have basic English comprehension. So we talked about this already a little bit. So open-ended versus closed-ended questions. Open-ended questions are very helpful in so much as you're getting the patient's issues in their own words, what's concerning them the most, and it also helps you kind of understand where they are mentally. So if they're not making any sense, this is kind of like, right, that open-ended gives you that AVPU. It helps work on your AVPU score, as well as your GCS a little bit. Close-ended is sometimes when the patient starts to ramble, like, well, when I was 14, I was riding a horse. Okay, but what's going on right now? Are you having chest pain? Are you having a hard time breathing? Okay, so sometimes you need to bring the patient back from whatever personal history story they might be rambling on about. Okay, this is essential. I know we talk about this in BLS a lot. Your AVPU. So everybody starts, your assessment of a patient by walking in saying, hey, what's going on, kind of thing. Sometimes you walk in, the patient's completely unresponsive, right? That's pretty easy. You go in, you're like, hey, wake up. You try to stimulate them, get a little painful stimuli. They don't respond. Easy peasy, unresponsive. Unresponsive patients, like, pretty much the least amount of work that you have to do to determine what their mental status is, because they're not going to respond. You try, you speak to them, they don't respond. You painfully stimulate them, they don't respond. Unresponsive. Boom, simple, done. same thing now. Okay, so you walk in, you say, hey, what's going on today? They don't respond. You stimulate them painfully, and they go, painful, right? You walk in, you go, hey, what's going on? And they look at you. And maybe they respond, maybe they don't, okay? If they respond and they're confused, they're not alert and oriented ×3, this is where I put them off as verbal for the most part, right? So if they're awake, they only look at you when you speak to them. They otherwise are kind of drowsy, but you can wake them up with a hey, verbal. Okay. Also, like they can be verbal if they're like really, really confused, because yeah, they're awake, but they're not alert. Alert patients are the most work because you need to clarify they're oriented as well. But this also falls into a little bit of a complicated area in so much as you have patients whose mental baseline is awake, alert, but not oriented. Okay, so your dementia patients, etc. In order to really clarify if they are awake, alert, and not oriented at baseline, you really need somebody else, a family member or somebody else there to clarify what their normal mental baseline is. So that's a quick review of AVPU. In order to be the most accurate kind of definition of what a patient's mental status is that you need to kind of also combine it with a Glasgow Coma Scale, right? There will be questions on the Glasgow Coma Scale. Without fail, the National Registry and state exam, etc., they usually be like, you have a patient who eye opens to speech, is confused, and moves to localized pain. What's their GCS? And you're like, crap, and try and math it out. So make sure that you understand, each section and where everybody's points kind of fall. A number of different special considerations that you have to kind of take into account when you're taking patient histories and communicating with your patients. Hostile patients, right? You might not be able to get a good history on them if they're very aggressive. Sexually aggressive patients, right? Those are ones you maybe want to have the same gender in the back of the ambulance. I personally haven't experienced a sexually aggressive patient yet, so that's exciting. Children and the elderly, right? They might not be able to understand you as well. Elderly, secondary to maybe being hard of hearing. Children, maybe like the language that you use needs to be simplified a little bit, depending on the age range. Cross-cultural and or language barrier, right? So like talked about this already with eye contact, not always the number one way to communicate with certain cultures. Language barriers are always a challenge. You have the language line there as a potential resource. I've tried using the language line a few times through telemetry, and I've had a hard time hearing it in the back of an ambulance. You also need to be able to actually verify the language that the patient's speaking, because sometimes like you'll find somebody who has like a weird dialect that no one really speaks. And there's other special challenges, right? So maybe you have a patient who has a tracheostomy and can't speak, okay? Or mental retardation or developmental delays, severe autism where they're nonverbal, right? So you need to also kind of take those things into consideration for that as well. Going back to AVPU real quick in terms of nonverbal, if the patient is nonverbal at baseline but they're awake, alert, and acting normally, you can kind of put them in the alert section. All right. Communications is really it's kind of a skill that takes time to develop. You really have to work on what your questions are going to be, how you're going to phrase things. Sometimes you might have to change your methods a little bit because some patients are not kind of meshing with you in the way you're approaching. Sometimes you have partners who like just aren't good at the interpersonal skills, and the way that they ask questions, if it starts to insult a patient, or intoxicated patients who want to be kind of insulted about everything and start getting aggressive. Sometimes you need to redirect. So just things to take into consideration. Questions, concerns, comments? No? All right. So The review sheet should be out and about. When this is done processing at the end of my little magic YouTube thing, I will send that out. And I will also send out a reminder that we are going to modify the lecture for next Wednesday for 7 a.m. instead of 9 a.m. Okay? If that's it, nobody has any questions or thoughts, I hope you all have a lovely day. Farewell.